So we'll just take some time here as people are still joining. And just a reminder of our 4 days of content. So we've just completed our first day on Monday, heard from an incredible array of speakers who were really speaking about the structural and the social determinants of health and how they affect people's health outcomes and their ability to access health care. And those intersections between health and social systems and how all of that really impacts on people's health and access to healthcare. Today, we will be diving into some incredible content from incredible speakers who will be highlighting Indigenous health needs across the country. We invite you to join us tomorrow as well. We'll be starting at the same time tomorrow, where we will be starting to look at what are those foundational reforms and shifts that need to be happening within our healthcare systems so that we can, identify and move on the opportunities that will help modernize healthcare to better meet the needs of everyone across the country. And then on Friday, if you are a patient or a caregiver or part of a patient or caregiver group, then you are welcome to join our patient planning session that takes place at noon Eastern for about an hour and a half, where we'll be sharing the themes coming out of the breakout groups from each day. So it's really important. Please do attend the breakouts and share what you're learning. We'll be taking the themes that come out of those. We'll be sharing them back with patients and caregivers and patient groups and talking about what's been happening in our working groups and seeing what we need to be doing together going forward through those working groups to prepare for next year and how we can work better together. So today's agenda, as I mentioned, we have an incredible lineup of presenters for you. We'll just go through the content. I'm not going to read the agenda out to you, but as you can see, a really exciting and insightful day that we have planned. Want to thank the two patient organizations, Save Your Skin Foundation and the Canadian Psoriasis Network, that are the co-hosts of this event, as well as Sharon Clark, who you'll be hearing from in a moment, who is an incredible contributor towards the Summit Steering Committee and really leads and guides our Indigenous health content. And a deep thanks to our sponsors who make this summit possible, as well as the pre-summit webinars. So thank you to Merck, Janssen, Roche, Bristol Myers Squibb, AbbVie, Amgen, Pfizer, AstraZeneca, and GlaxoSmithKline. Also, a big thank you to Innovative Medicines Canada, who provide some support for our working groups that continue working on themes and issues coming out of these summits in between the summits. So it's an opportunity for patients and caregivers and patient groups, and sometimes some other stakeholders do join as well, to really work on some of the common issues and opportunities that are identified and to keep advancing those together in between summits. So thank you so much. Thank you so much to all of the organizers, to our interpreters, Ciro and Oksana, to our translator, Rochelle, to our tech support team, Lance, Sylvia, Katie, Taylor, Jasmine, who's also helping with the editing. And if I've forgotten anyone, I apologize. It takes an incredible team to pull off this event. Thank you. So for housekeeping, during plenary, you will be muted. The videos will be off. We are recording the English and French session so that we can share it on YouTube for people who can't be here today. If you would like to access the French interpretation, just click on the world icon at the bottom of your screen, click mute original audio, and then select French. However, the French interpretation will not be working when we're screening videos and when we're in breakout sessions. So you can use the closed captioning in order to get the translation of the videos captioned for you, and also in the breakouts. If you identified as a French speaker, we did put you with a bilingual facilitator, but if you need, you can also use the closed captioning in the breakouts. During the breakouts, you can take off your mute so that you can speak and share, of course. And if you have, we encourage questions. There will be moderated Q&A after every speaker and every panel. So please add your question into the chat at the bottom of the screen and press enter. Or if you want to use the Q&A, you can put the question in there as well. If you have technical difficulties at any point today, please contact Lance Lee via the chat function. And please, if you're inspired, disturbed, excited by what you're learning today, please do share it on social media and use one of these hashtags to help flag that this conversation is happening. So here we go. I would love to pass the mic over to my good friend and colleague, Sharon Clark.
Okay, thank you so much for that introduction, Leah. You're always too kind. Anyways, good morning, everyone. Welcome to day 2 of the Patients Defining the Future of Healthcare in Canada. And I really believe that the importance of the patient voice, I work for the Saskatchewan Health Authority and really need to hear those patients' voices to start making those transformational actions. So I'm sure all of you will share with me that yesterday's session was exceptional. It was informative and eye-opening and very inspirational. And we received so much positive feedback and we want to build on that. So today we've got some wonderful lineup of speakers and it's going to be just as wonderful. So just a quick word about some of the themes from yesterday. We talked about co-design, the importance of co-designing with people of lived experience, and this is really the patient voice. And also having coalitions to strengthen our work and make it sustainable. And again, patients have to be part of those coalitions. And of course, impacts of intersectional discrimination. All of us within the healthcare system often encounter this, and the only way we're going to deal with it if we work together. And if you have a chance to go back and review the recordings, please do. They were absolutely wonderful. So anyways, that's enough from me. I'm sure that you are excited to hear from our speakers for today. So without further ado, I will introduce you to our wonderful keynote speaker, Mackenzie Daybush. So Mackenzie works at the Ottawa Hospital as the program coordinator for the Regional Indigenous Cancer Program and is also the co-chair of the Ottawa's Hospital's Indigenous Employee Network. Mackenzie is Ojibwe from the Mississauga First Nation, number 8 in northeastern Ontario, where she is a status band member, Bear Clan and intergeneration residential school survivor. Mackenzie holds diplomas in social services, child and youth counseling, and Indigenous studies. Her work involves child welfare, education, case management, and crisis intervention in the nonprofit and residential sectors. Her passion is in the field of healthcare, and she advocates strongly for social justice and equitable service for Indigenous people. Mackenzie brings a wealth of knowledge from the community level for both urban Indigenous populations and on-reserve Indigenous population. She hopes that one day all Indigenous and marginalized folks will experience a place of belonging within the medical sector. So I'll pass it over to you, Mackenzie, and thank you very much for agreeing to come and speak with us.
Sorry, apologies. For the benefit of our attendees, Mackenzie actually had a video, and correct me if I'm wrong, Mackenzie, that she'd like to screen with us just before she comes on to speak. So without further ado, I'm going to share a video that she made with everyone, and then we'll get to the keynote.
Ani, my name is Mackenzie Daybush. I am Indigenous. I'm First Nations from Mississauga First Nation, which is upwards towards Sault Ste. Marie, Ontario. I am an intergenerational residential school survivor. I am the first generation of my family not to attend a residential school. I'm a social worker and I'm a mother. I currently reside in Ottawa, Ontario, Algonquin Territory, and I am Ojibwe myself. I was asked to come speak today on some of the social biases and injustices that occur with Indigenous people in healthcare.
qui a eu lieu
I'll share
et qui
a
frappe les
scenario
autochtones.
that occurred
Je
with
peux vous parler
myself
de scénarios
accessing healthcare.
sur lesquels, dans les
3
soins
years ago, when I
de
was
la santé,
obtaining
quand il y avait
prenatal care for my
3
daughter,
ans, j'avais une
the
fille
provider was doing the
qui allait
intake
naître
with me, and I
et
was asked multiple
on
times
m'a
if I
demandé plusieurs
was
fois si
drinking, using
je
drugs, or smoking,
buvais,
and I was asked
je
multiple different
fumais
ways
ou
throughout the
bien je prenais
appointment.
des stupéfiants.
It wasn't until I
C'est seulement
disclosed and
quand
chose
j'ai
to
dit
disclose
ce qui
that
s'est
I'm a
passé,
social worker and
puisque
I'm
j'ai
an
dit
advocate in the community,
ce qui s'est passé. Je
and I'm an
suis un
intensive
agent,
case
je
manager for the
suis un
Indigenous
agent social.
population.
C'est à
Following
ce
that, the
moment-là
tone of my provider completely
que
changed.
maintenant le
It was
ton
focused on my prenatal
des
care
intervenants a
and
complètement
not so much
changé
on if I
et
was drinking or using drugs.
ils voulaient vraiment savoir
Fast forward to when I was giving birth to my daughter, I was
que
in
maintenant
active
pour donner
labor,
naissance à ma
and knowing very
fille,
well that birth
je
alerts are
pensais
still
que,
happening.
et je sais que ça arrive à plein de monde,
I was in labor and I was going through
j'étais
A
en
through Z
train que de donner
to make
naissance
sure
à ma
that I
fille
had everything in place.
et je voulais
Who I was
m'assurer que
going to
tout était
call,
là.
my lawyer's phone number,
D'ailleurs, il y avait
if my
aussi mon
child was
avocat,
apprehended.
j'avais son numéro de téléphone à côté de moi.
And a birth alert is when a
Et ce qui s'est
professional
passé, c'est qu'il y avait
notifies social services
un
that an
prestataire
Indigenous mother
qui est
is
venu,
giving birth.
qui a indiqué
And
qu'il
from
y
that,
avait
usually an
une autochtone qui était
apprehension
en train de
occurs.
donner
So
naissance.
child welfare would come and take your
Et
baby
il se
away.
pouvait que
And then
maintenant,
you need to
la
prove
protection de
to
l'enfance allait venir et
social
prendre ma
services that you're a
fille.
fit person to be a parent.
Car on allait dire que moi, je
And
n'étais pas
oftentimes
quelqu'un
these
qui pouvait devenir
apprehensions
une mère,
aren't
qui était une mère convenable.
with cause. So having known that, what was supposed to be a joyous time in my life was
Ce
a
qui
very
doit être
stressful
maintenant un
time.
moment vraiment
Just
très heureux
imagining that
pour
my
moi,
child could be
devenait
taken
maintenant
away
quelque
and
chose
she's
qui
not
me
even here
rendait
yet.
folle, parce que je ne
So
savais pas si on allait
I had my
m'enlever mon
backup
enfant.
plan and I was
Et
ready should this happen.
j'ai
Thankfully, it didn't.
Mais
There was no cause
heureusement,
for
rien n'est
social
arrivé.
services to be called.
On n'a pas dû appeler la protection de
But that's
l'enfance,
not the case
mais
for
c'est pas
many
toujours le
mothers,
cas
Indigenous
pour de
mothers that are
nombreuses
giving birth.
mères autochtones.
And having me being visibly
Et
Indigenous, like I said, it
puisque
was a
je
very
suis
big
clairement
concern
autochtone,
and fear for me.
ça soit tout de suite.
With that being said,
Et on dit cela,
it absolutely makes sense to me
ça a du
why
bon sens pour moi,
Indigenous people don't access healthcare,
que
why Indigenous
pour
screening
expliquer
rates are
pourquoi
so
les
low.
autochtones
It
ne
was
vont
only
pas,
in 1981 when the last
n'ont
Indian
n'ont
hospital
pas accès, ou
closed.
plutôt ne veulent pas accéder aux
So
soins
when Indigenous people
de la
today
santé.
present at
Donc
appointments, it's
aujourd'hui,
often very
quand il
tight-lipped.
y a quelqu'un qui va,
There's no
en
expression
général,
of
ils ne veulent pas
concern. It's just kind
parler,
of
ils
a
restent la
nod,
bouche
accepting
bée,
whatever your
ils ne vont pas
doctor needs to tell
parler,
you, in fear
et
that
ils
if
craignent
you say
que
something
si on dit quelque
wrong, or
chose,
if you're
il se
truthful, or if
peut
you express
que la chose
concern,
qu'on dit
that
ne
these
soit
will
pas
be used
bonne,
against
et
you.
donc on va l'utiliser contre toi.
Just knowing the history
Et ça,
and the
c'est à cause de
trauma
l'historique,
and
des
things that very real have
traumatismes
happened and are
qui
still
ont
happening
déjà eu
today.
lieu, qui continuent.
Oftentimes this will lead to
Souvent,
Indigenous patients being
quand on
labeled as
regarde ces
uncooperative,
personnes, on
not
dit
wanting
que c'est à
care,
cause de
not showing
cela
up for
que
appointments, lazy
les
for not getting
autochtones ne
their cancer
coopèrent
screenings done
pas,
or
ils ne vont
blood
pas venir
work,
au rendez-vous.
when that's absolutely not the case.
Mais ce n'est pas le cas.
The case is
Le
that
cas est
we are
que
struggling with
on lutte
intergenerational trauma,
avec ces
generational
traumatismes
trauma,
qui ont été passés de génération en génération,
things that have happened to our family members
des
that
choses
shouldn't
qui
have
ont eu
happened.
lieu aux membres de notre famille.
So, rightfully so, Indigenous people
Et c'est
do
pour
have a
ça
hard time with
que
healthcare.
les gens ont du mal avec les
With
soins de la
all that
santé.
being said, I hope that the takeaway from
J'espère que
me
maintenant,
sharing my
les gens
story
vont
is
apprendre,
to be
grâce à mon
compassionate, to
histoire.
be understanding,
On peut aussi que de
to do your
comprendre,
research, to
faire le
expand your
travail,
knowledge on the Indigenous history and traumas,
de façon telle que
so that you can better serve your patients.
vous pouvez maintenant toujours desservir les patients.
Hi, everyone. So as it was, that was recording of me from another speaking engagement that I was invited to. And like I said, so that was probably my first, for me, my first write out, being stereotyped as an Indigenous person, and being stereotyped not by the way I looked or my clothing or how I presented myself. I was stereotyped and labeled as you know, an alcoholic or a drug user based on when my provider asked me what my nationality was. So it's a typical question. I know that's asked at an intake appointment. So I did self-identify. I am First Nations. So that was noted on my chart. And like I said, following that, the questions were very repetitive, almost accusatory that I was lying and that I, in fact, was drinking or using drugs or smoking, when that wasn't the case. And it wasn't until, like I said, I disclosed my professional background, and you know, I was just coming to my appointment during my lunch break, so I was dressed as I would be today. And then that's when she stopped kind of asking me these questions if I was harming my unborn child. So with that takeaway, and then having to plan, you know, for 9 months of being an Indigenous person in the healthcare system, not only just generally healthcare, but within maternal health, I did have to plan. I didn't know. My previous work was an advocate and case manager for the Indigenous population here in Ottawa. So oftentimes I was on, you know, calls with social services and trying to get files closed and that type of thing. So I knew the system well, and but that's not the case for every other Indigenous mother that's coming into our healthcare system. They might not have the resources that I had because of my, you know, my work experience and who I know within the field. So I just think of all of those that, you know, didn't have a strong voice or didn't speak up for themselves, and ultimately their child was placed in foster care system without a just cause. I know that for some that might seem, it's terrifying, it's scary, and it's still happening today. Birth alerts have been banned from an actual, like a hospital setting. It is banned, but that's not to say that it's still not happening where a professional does have those stereotypes and unconscious biases towards Indigenous people and would make that call and could have allegations. And with social services, all allegations need to be investigated. So no matter if you're calling for whichever reason, ultimately that mother will be investigated, which again is causing trauma to the mom and her family. So that is just in my experience with maternal wellness. Now, in general, in the healthcare system, once somebody, an Indigenous patient presents themselves, and they do have that negative experience of low quality care, or, you know, and then they end up not returning for follow-up care. And it's not just the one person that it's affecting. The Indigenous communities in your respective territories and nations, typical to mine here in Ottawa, word travels fast. It's a small community of people in these urban centers, and you know, they'll be sharing their negative experience, and it has this ripple effect of, well, then with that one person's negative experience, now you have 30 people that won't be presenting at the hospital in fear or of having negative treatment or being labeled and stereotyped. And that's in today. And then speaking of the traumas in healthcare for Indigenous people, there's so much fear with, you know, with residential school. So as we know, that wasn't too long ago. My father's a residential school survivor, and I'm the first generation in my family not to attend residential school. So it's not like it was hundreds of years ago. So there's that trauma. And then you've also got the 60s scoop where again, Indigenous children were taken away from their families, placed for adoption, advertised for adoption in newspaper articles, and then never came back to their community. So that's two instances of loss of culture, loss of identity, and mistreatment. And then even getting in today, we're experiencing what they're calling the millennial scoop, which is the overrepresentation of Indigenous children within the foster care and social services system. And again, with the birth alerts, another one. And it wasn't that long ago when the last Indian hospital closed. So for those that don't know what an Indian hospital was, when Indigenous people would need medical care, we weren't allowed to attend the regular hospital. We needed to attend the Indian hospital for our specific population. And oftentimes, people were sent there and never came back. So they ended up either going as children and passing away, or going as children and being adopted without the parents knowing. Or they would go for medical care and their medical care was not up to par. There's often treatments and sterilization and research going on Indigenous people while they were there, and they wouldn't go home. They would oftentimes pass away. And then that kind of trickles in today. So a lot of our patients and populations of Indigenous people that aren't urban, that aren't living in a city center, that are living back on their First Nation or their territory, they need to travel for medical care. So a lot of these rural places don't have hospitals. They'll maybe have a healthcare center or a clinic. And then if, there's something wrong or they need specialized care, then they need to leave their communities and come again to these big cities with these big hospitals. And as you can imagine, someone in a remote community with a small population, you're surrounded by your family, your culture, your traditions, and then all of a sudden, you went to get help because of your back pain, for example, and then you need to leave. And what could be a couple days stay could end up being 2 weeks to months, and then you can't go back until you're better, and all that time you're away from your family. So with all that being said, with the trauma today leads to high anxiety for Indigenous patients coming for healthcare. Like I said, we do have the lowest screening rates. Indigenous people aren't getting screened for cancer. Diseases are being found at a late stage because folks are not wanting to come to the hospital until it's the last resort, and they're in so much pain that when they are accessing the healthcare, it's too late. And they even might come and then they end up passing away here because their disease is so late in being found. Or altogether, just not accessing healthcare at all. And often, like I said, when patients do come to their appointments, like I said, oftentimes it's like a yes or no answer, not really asking questions, not really using their voice or questioning or asking for a second opinion, which leads to patients accepting treatment without knowing fully what they're accepting, or just refusal of treatment because they just don't want it. And with all of that, so with patients that do come, and there's always something to keep in mind about the level of language you're using. So to avoid high level medical terminology, I've seen patients that are adults, but they can't read. They have a hard time writing. So things to keep in mind, like a lot of visuals, taking your time with this patient. And on top of that, there can also be the language barrier, especially when English isn't their first language. So it's just something to be aware of and to know
to know your resources for translators. And of course, with all of that being said, when Indigenous people presenting at hospitals, I know that a lot of hospitals are trying to get Indigenous self-identification done at intake, and which is okay, you know, you need to ask, but the ask is in hopes to collect data. And as we know, you need data for program funding and position funding in these institutions. But the problem with hospital data regarding Indigenous patients, and that's First Nation, Inuit, and Métis, is knowing everything that I just spoke about with the trauma and the barriers and just negative treatment or not at par with the treatment everyone else is getting. Folks aren't going to self-identify. You know, had I not self-identified at my medical appointment, I really doubt that I would be getting asked if I use drugs or if I drink alcohol while I was pregnant, multiple different ways during my appointment. So right there, data, again, people aren't identifying. Or what we do see is non-Indigenous patients that do identify as being Indigenous in hopes that there's some type of financial gain, that they'll get something out of it, or yeah, that they'll just get something for their benefit if they self-identify, although even though they're non-Indigenous. So with these two factors, you know, collecting the data is going to be skewed either way. You're going to have Indigenous people that aren't identifying and then non-Indigenous people that are identifying for their personal gain. So with the no data or limited data or skewed data, whichever, it leads to no or less Indigenous specific programming. So like I said, I do work in a hospital. I am the program coordinator for the Indigenous Cancer Program. And I do have, in our program, I have an Indigenous nurse navigator that does, supports patients, advocates, and then we also have a doctor on our team as well. That is our regional Indigenous cancer lead. So there's 3 of us here. 2 of us are at the hospital, but that's only 2 of us, and we're only cancer specific. And it's only 2 of us, and our program covers the Baffin region of Nunavut as well, and the 3 Ottawa hospitals here, and our Champlain region. So we've got a wide area that we cover to support patients and families, and we're only 2 in, and we're cancer only. So with this no data, it leads to less of coordinators, less navigators, less Indigenous focused social workers, less elders. We know the data, we know that the need is there, but the ability to prove it in the numbers for program development aren't there. So it's the data collection, we're not there yet. We know that the programs are needed. There's oftentimes, like I said, my counterpart and myself are just 2 people with an 8-hour day. But then we get calls for cases outside of cancer. So, you know, when someone really needs that advocacy, there's being, they would like advocacy in their care and their voice to be heard, but we're cancer, right? So we do need the data. It's just a matter of how are we going to collect this data. And another question that we hear from the community is, if I do identify as First Nation, Inuit, or Métis, then where is my data going? Why do you need to know that about me? Why does that need to be in my medical chart? So again, it's skewed data. I always, when I am speaking, I know that a lot of people in healthcare, you get into healthcare because you want to help people, you want to, you're there for the person and the patient. And you think that you don't have any stereotypes or any biases, but there are things, a thing called unconscious bias. So it's something that you're not aware of, but it is a bias. So you have grown up just thinking this way, but you're not aware of it. And then it does in turn affect patient care. So I like to do some myth busters, and it's things that I've heard, and I'm sure that you've all heard that aren't true. So we often hear that Indigenous people have free healthcare, free education, pay zero taxes. We've got free housing and free medical care with the status card, and that every Indigenous person has a status card. So none of that is right. Healthcare, the only healthcare that an Indigenous person gets is not, well, we all have the same. We've got, here in Ontario, we've got a no-HIP card, health card. And then for the free medical care, if you're needing prescriptions or if you're needing assistive devices, folks think, well, you know, my patient's Indigenous, why they can just use their status card? Well, there's a couple things. So with a residential school, 60 scoop, a lot of people lost their identity, and they don't have a status card because they can't prove their identity. To get a status card, you need to be able to prove your lineage, your family tree, your original birth certificate. It's a process. So no, not everyone has one. And Métis do not have a status card. They have a separate, for us, it's Métis Nation of Ontario cards, which do not cover medical. The Inuit do have their beneficiary numbers, and it's similar to having a status card, but not everyone has them. So you can't assume that. And again, I always hear, well, why you're Indigenous, why didn't you go to school? We do hear that. You know, your schooling's paid for. Why aren't you doing post-secondary? Why aren't you working? Education isn't free. It's a whole process, and it goes by band to band. So depending on your First Nation, depending on how much money your First Nation is allotted for education, and if you are able to get accepted, it's not a free-for-all, essentially. And even if you do get sponsored for your education, you know, it's a certain amount, then you need to cover the rest, or you need to cover your books, or you need to cover your housing while you're out for post-secondary. And then you do all of that, and then you still need to report your grade point average. So if you're not at a certain grade point average, then your funding can be taken away. So there's a lot of factors in the education piece. But again, it's something that we've all heard. Indigenous people have free education. And again, with the taxes and, you know, saying that Indigenous people pay zero tax, not true. We do pay taxes. And I live off reserve, so my money is still taxed. I don't get, you know, just non-tax. No, it doesn't work like that. And there's no free housing. I mean, the housing on a reserve is scarce. I mean, they need to build more. Oftentimes, it's multi-generational living in a home, many people. So there's, again, no free housing. I wish. And then another thing, if you don't have a high population of Indigenous people or reserves close to your city, you'll think that all Indigenous people live on reserves. No, in Ottawa, we actually have a very high urban Indigenous population. So again, that's not true. And we often hear that, well, Indigenous people are so, like, they're hard to build relationships with. You know, there's, which again is not true. It is a different lens when you're trying to build a relationship with an Indigenous patient. It's the lens of taking the time for trust, allowing the patient to feel comfortable to speak with you. And that's not going to come, you know, over 2 appointments. And it's not going to come in rushing appointments and, you know, being upset if your patient no-shows and, you know, blaming the patient. That's not going to happen. So with all of that being said, I know that I don't want to sound so doom and gloom about Indigenous people in healthcare. I do. So I guess looking forward is, what can we do next? You know, this system that we'll say has not been benefiting Indigenous people. What can we do to make it better? What can we do to, you know, lower the mortality rates of Indigenous patients because they're presenting so late in their care, or not at all, or they don't come back for appointments because they had a negative experience? I would have knowledge in the histories that I shared with you today. If your patient is showing up for their appointment, they've just gotten bad news, and for example, they might raise their voice, they might seem like they're angry, you know, security gets called, and then this person's escorted off property, when in reality, the why is that patient just received probably the worst news of their life with intergenerational trauma. Fear and sadness often isn't displayed, so it comes out as an anger when really this person is anxious, and, you know, they're not trying to raise their voice, or they're not trying to come off as aggressive. And right there, security is called and they're escorted off. We do know that Indigenous people have such a high population in our prison systems as well. That patient's probably not going to come back. And again, the trickle effect of, this is what happened at my doctor's appointment. So knowing that all of these traumatic issues and the why is your patient not showing for their appointment? Why do they keep rescheduling? And instead of just brushing it off and labeling your patient as a chronic no-show, or they don't take their healthcare seriously, just remember the traumas that I shared with you today and put yourself in that person's shoes for a minute and realize everything that they've been through, or their family, or, you know, their friend, because you will not meet one Indigenous person that doesn't know someone, or that hasn't attended a residential school, or knows someone that has, or is related to someone that has, or the 60s scoop as well. So stepping into these institutions is a lot. And with you not labeling, or being aware of your unconscious biases and your stereotypes, and remembering that this person is a human with feelings, and when you see these negative behaviors, just remember to ask why, what is going on? Why are they acting like this? I mean, don't ask them, but in your head. Another way to help is knowledge of culture and traditional practices. And I know that the term Indigenous is a pan, so Indigenous includes First Nation, Inuit, and Métis together, when in fact each one is totally different. So knowing the distinctions in between First Nations populations, Inuit populations, and Métis populations. For example, I'm First Nations, and we're known to practice smudging. Smudging typically is not in practice of Inuit. It has been adopted by Inuit who were urban and, you know, with different First Nations groups. Sure, and that's fine, but it's not to assume that, oh, because they're Indigenous, they're going to smudge. And even if a First Nations person, that doesn't mean that they're automatically going to want to smudge. So knowledge of the culture and traditional practices and thinking in a distinctive way and not a pan-Indigenous way is super important. And knowledge of the population and where your clients are coming from. For example, if you are having someone come in from a remote community and you're telling them that they need to do X, Y, and Z, but they don't have that in their community. And then, for example, and then they say, okay, and then they leave and they can't do X, Y, and Z because they don't have that in their community. So knowing where your population comes from, knowing which territory you're on. Right now, I'm on Algonquin territory. I'm not Algonquin, I'm Ojibwe. Algonquin and Ojibwe share similar practices, but not are the same. So, like I said, Indigenous, again, is the pan term, but just to know your distinctions, know the territory that you're on, and know the territory that your clients are coming from. And not just but also aware of the Indigenous resources in your communities. Who are they? Does your organization have a working relationship with these Indigenous communities? Are you collaborating with the Indigenous agencies? Are you collaborating with them? You know, because collaboration in care is really important and the holistic aspect of care. So knowing the Indigenous resources that you have and that you can use to support your patients. And always encourage the voice of your patient. You know, if you see that they are nodding, not really asking questions, it's okay to say, you know, do you understand? Have your visuals, you know, print some of the body part that you're going to be talking about so that they can understand. If you know that this person isn't English speaking, book your translators. Anyone that is not English speaking does have a right for a translator, and knowing where you can do that. And always encouraging the voice of your patient. And to encourage the need for funding for Indigenous specific positions within healthcare. And the uptake of Indigenous people applying to work in the healthcare system. Again, every Indigenous person that is coming to a hospital has some type of trauma, and myself included. And I'm working in the hospital, but how do we encourage the programming and encourage the hiring of Indigenous people? So I guess that for today, the key takeaway I would say is to know the history, ask yourself why, instead of assuming this like I said, with the behaviors and the missed appointments, ask yourself why. Knowledge of culture and traditions in your area and the population you're serving. Sorry, I was just reading a question in the chat. So above and beyond provider changes, what are foundational systemic changes that are needed for high quality care? So including the safely collect First Nation data to support improvement. For any work that's being done regarding First Nation, Inuit, and Métis should always be consulted with your local First Nation, Inuit, and Métis communities. Indigenous people need to lead the way Indigenous organizations or collaboration is going to work. So with the question on the ability to safely collect data to support, you know, the quality improvement. It's asking the Indigenous people in your area, are they comfortable with that? How can we support what would make them comfortable with data collection? Yeah, so I would say in terms of data collection and how to move forward with that, I would say is the need to engage with the Indigenous communities, the Indigenous organizations in your community to figure out how can we do that that's going to make it helpful and make you feel safe. And I think I'm coming up on time. So with everything being said, I open the floor for anyone who may have any questions for me, and I'll do my best to answer. I never claim to be the know-all or end-all for Indigenous patient care, so I'll do my best to answer from both my clinical perspective as well as an Indigenous person myself who's obviously has to access healthcare. So feel free to ask and I will answer.
Okay, thank you. Thank you, Mackenzie. Thank you very much for your very comprehensive health presentation. And, oh, am I on there? Yeah. And I think very much food for thought. And so we look forward to answering some of these questions. So my question too fits in with the one about data support or supporting capture of data, because here in Saskatchewan we're thinking of doing the same thing, is collecting data, and we have collected data, but we're not getting the positive response we wanted, and often the response is from non-Indigenous people, because we have to ask everybody the question, and some of them are very vocal about being upset that we would ask them that question. So we're dealing with some of those reasons why. So my question is, you talked about negative treatment in hospitals following data collection. What do you think a hospital or a health system can do to alleviate that kind of response from the staff?
Sorry, what do you mean from the staff?
Like you talked about when people are afraid to self-identify because they feel that they're going to get negative care. So if that's true, then what can we do to help alleviate that situation where health staff may be negative once they find out they're Indigenous?
Is it the question on how to ask if they are self-identifying, or
no?
Okay.
Say I go into the hospital and they ask me to self-identify, and I say I'm not going to self-identify.
Yeah.
Because I know you're going to treat me badly. So if I think that, do we know that the health staff are going to treat them badly, or there's a potential of it? And if so, how do we address that part of it?
Yeah, so I think that it's not going to be something that can be done, overnight. It's going to need to have that ripple effect where someone does have the positive experience and does share it with the community, and then so that the community will start to self-identify. We always say as First Nation people that change from the trauma that's happened is we'll see the change in 7 generations. We'll see the ultimate goal of folks not feeling the intergenerational trauma in 7 generations. You've got me as 1 generation, my daughter's 2. So for us to come to a time where Indigenous people feel safe, they're not living with their traumas, it'll be 7 generations. In this time, it's always nice to have some identifiers that maybe your staff are an ally, and not to just be an ally just because you're going to be an ally, but to have it as a visual. So oftentimes just walking around the hospital, I have on my lanyard, I have every child matters. And I know that that's across Canada. You know, if an Indigenous person sees that, oh, that speaks to me. That might make them say, okay, you know, you're aware of what happened there. And it will make them more comfortable. It's small. It may seem like a small thing, but even with my colleague and I, we have pins and different things on our lanyard that makes us identifiable for Indigenous people. And I think that is just a subtle kind of way to show that I know that you could be anxious to be here, and without even saying something. So I would say, yeah, as something just to start that process. It's not going to be something that happens overnight, but we've been told in 7 generations.
Thank you. Thank you. Excellent. Okay, and somebody says, thank you for the education. How can we include more culture into our medicine?
So to include more culture needs to start with knowing the histories of the territory that you're on. So getting teachings, learning cultural safety, will be able to incorporate culture into your practice. I know that here at our hospital, we have the opportunity to perform, well, patients can perform their own smudging ceremonies as a part of their healing. As we know, you need your culture for healing. And so again, knowing your population and knowing what they practice in terms of healing. So for example, smudging brings a sense of, it could ease anxieties. You know, oftentimes we've had people wanting to smudge before a surgery. And then if we have patients that aren't allowed off the unit, then they can have their own medicine bundle, or we can provide a dry smudge. So we do have things like that. And, you know, we do have physicians that will, I guess, refer patients to us, or even just letting patients know that these services are available in-house, I would say is the start.
Okay, thank you. There's also, let me see. Thank you for this candid insight into lived experience of a young mom. Also want to give a shout out to CanSolve CKD and their Indigenous program, and they've got a link in the task there. Okay, and let me see, what else? Oh, here's one. Any issues for Indigenous patients to get to their appointments? How can they get to their appointments? Transportation-wise, as being sometimes a remote.
Yeah, so in terms to get to, like if someone's needing to travel a far distance to get to their specialist appointment, if they do have their status card, they could go through non-insured health benefits. So this is a government program that will be able to provide, sorry, we're having that nationwide emergency alert going on the test. Yeah, so NIHB is able to provide transportation funding for the patient to travel for their appointments if they're traveling a long distance. And oftentimes that's either your social worker or case manager that's in your units to assist with that paperwork. And if the patient is a child, you can also apply for medical transportation funding through the Jordan's Principle and the Child First Initiative. So Jordan's Principle is for First Nations children that either have their status card or their parents has a status card, or the Child First Initiative is for Inuit children. So there are pockets of funding, again, only if they are status or a beneficiary.
Okay. And Jordan's Principle, maybe you can say a few words about what that is.
Yep. So Jordan's Principle is it's funded, it's under, I forget where, sorry, Indigenous Services Canada, I believe. And so what they do is you would submit an application regarding your child's health, and Jordan's principal has 24 hours to 72 hours to provide a response and to let you know if you've been approved for funding. Typically, Jordan's principal won't refuse. It was created, unfortunately, from the passing of a child whose name is Jordan, because he was stuck in jurisdictional issues on who was going to pay for his medical funding, whether it was going to be the province or the country. And yeah, in all of his stay, his entire life was lived in hospital. He wasn't able to leave for travel because nobody would do the funding, essentially. So then that's when Jordan's principle came into place. And sorry, that's a big paraphrase, but it was unfortunately put in place due to the passing of a child.
Okay, excellent, thank you. One of the panelists also put a documentary about Jordan River Anderson, the child that sponsored Jordan's principal, and the link is in there if you want to have a look at it. Okay, so let me see, any more questions here? I have another question. I don't know if I should, but okay, here's one. This has been a fantastic educational presentation. Thank you. I appreciate all of the important considerations you shared about providing care to people from different Indigenous backgrounds. Any suggestions for resources that you use that are available publicly to help education providers on things like implicit bias?
So some of because I'm here in Ontario, I know that Cancer Care Ontario offers cultural safety on their website, and you are able to put the hours towards, for doctors, you're able to use those hours that you do. And then there's also the Sanyas cultural training that is based out of Vancouver, I believe. And so I would say starting there.
And I think Sanyas is also available in Ontario.
Yes.
Yeah. Okay, and some people aren't getting the links, but we'll make sure that everybody's getting them. It could just be a delay, a time delay, but so look forward to that. Okay, so I think that is the last question, except for my question, of course. So in Saskatchewan, we have navigators and health educators, First Nations, in our 3 tertiary hospitals in Saskatoon and also in Regina, Prince Albert. And we want to have more because we recognize the value. So when you're thinking about the work that you do in terms of cancer care, what do you think are the greatest impacts of your interaction between the Indigenous patient and the care provider?
In terms of like the positive impacts of our roles?
Yes.
Yeah. So oftentimes, and we've seen it again, but we'll be flagged or we'll see a patient. Oftentimes we just happen to meet patients while we're not walking around, and they see our and we just have a conversation. What we've noticed, and also in crisis situations where we've been called in, is when we're not on a file or when the units might not know that our team is involved, care is going one way. And as soon as we kind of step in, not so much, you know, once we have our name on the chart, we do know that the way that the care is going does flow more positively. Whether we're making, daily visits on the unit to check in with the patient, or our names are just on the chart and we're kind of keeping eyes on the file. So yeah, with that being said, it's where the patient expressed that they aren't happy, and then we come in and the patient's voice is heard.
Okay, thank you. Thank you. I think for a lot of people, that's an important piece to recognize, that having Indigenous people working in the hospitals is not just for the Indigenous patient, it's to help the hospital staff and the system work a lot better with their patients.
Mm-hmm. And even like we'll just get calls and, you know, folks asking for resources in the area that are on different units, or they're kind of at a loss on how to support this patient. So then they reach out to us. So it's, again, not our position. It is for the patient, but we also do support the providers here, the nurses and social workers as well.
Okay, excellent. Thank you. Also, another question here. For national patient organizations with smaller patient populations who want to provide resources to First Nation, Inuit, and Métis individuals, are any common mistakes you've seen that we should avoid?
Yes, so a common mistake that we do see is, again, when I was explaining the term Indigenous. So your client may identify as Indigenous, but they're Métis. So you wouldn't offer them like support for an Inuit patient because they're not Inuit. So it's just these little, taking the time in your practice to know the difference between First Nation, Inuit, and Métis, and ensuring that when you are providing resources or support for that person, that you're doing it for the right nation. So like you wouldn't offer a First Nation patient country foods such as seal, because that's not their practice, that's Inuit. So it's just knowing these, and although it might seem like a subtle mistake, these are things that patients remember. So just to be self-aware and knowing where your patients come from.
Okay, thank you. Here's another question. I know traveling clinics are used in some provinces for medical clinics in remote communities and Indigenous communities. Is this something that works well, such as prenatal and maternal care, and could be expanded for other areas such as cancer and cardiovascular disease?
Yes, so it is, because like I said, our program also supports the Baffin region of Nunavut, and oftentimes we see those patients come down and they're here so far away from their family, don't speak the language, etc. So our goal is to have care closer to home, care in their community. And right now, specifically with my program at the Ottawa Hospital, is they do follow-up clinics for cancer patients in the north, so that they're not having to travel down here, be here for a week for, you know, one appointment or two, and going back home. So we are in the process of building that clinic, but that is our goal, is care closer to home. We know that folks heal better when they're eating the food, they're eating their home food and not hospital food. They're surrounded by their family and their loved ones. They're comfortable in their own space, and they're with their culture. So it is, care closer to home is definitely beneficial.
Okay. Okay. All right, thank you. Are there any more questions?
I think you found them all. Thank you.
Awesome. All right, well, thank you very much. That was really awesome. And we look forward to liaising with you in the future. I'm sure that you'll be, some of the attendees will reach out to you. I think this is pretty awesome. And I'm very happy that the Ottawa Hospitals has done this work, because we know it's very much needed. So from all of us, thank you very much. And we'll talk to you again.
Yeah, thank you for having me, and thank you for everyone for listening.
Okay, thank you. Okay, and we've got some comments in there. Maybe you can read those, and that'll be good. Okay. So I guess we'll move on here. And okay, we're looking to our next speaker. This next presentation is Dr. Jason McVicker, and his presentation is called A Theater of Reconciliation, Surgical Outcomes for Indigenous Patients. So Dr. McVicker is from Kamloops, Royal Inland Hospital in British Columbia. And he's also a Métis from the Red River Settlement in Manitoba. He was born in the Northwest Territories and raised in Western Manitoba. He was trained in Manitoba, Queen's University, and Toronto. And he practiced in Ottawa for the past decade and is now an anesthesiologist at the Royal Inland Hospital in Kamloops, British Columbia. Jason has worked for Doctors Without Borders, is a trustee of the Canadian Anesthesiologist Society International Education Foundation, is on the Pain Committee of the World Federation Society of Anesthesiologists, and completed a public policy fellowship with Action Canada. Dr. McVicker was lead author for 2 CMAJ publications on surgical outcomes for Indigenous peoples. His current active areas of work include supporting the access to health resources in rural and remote communities and improving surgical outcomes for Indigenous peoples in Canada. He was awarded the University of Ottawa Faculty of Medicine Social Accountability Award this past year. And lastly, he's a proud father of 2 children, and who sounds like they do some downhill skiing. And he also loves to do photography. So thank you very much for coming to join us, Dr. McVicker. And I'll hand the mic over to you.
Thank you very much, Sharon. I really appreciate the introduction. Tanshi Jason Deshinikachun. That's Michif for hello. My name is Jason. So Michif is an endangered language. The total number of Michif speakers in the world is about 1,200, and that's about equal to the total inpatient beds at UHN in Toronto. So I'm clearly not a Michif speaker, but it's always nice to be able to do an introduction in Michif. So I'm very grateful for the warm welcome and the invitation from Louise Binder to be able to contribute to the conversation today. We met at the Inuit Cancer Conference that was organized earlier this year, and that was in Iqaluit, and that having the conference there itself was an act of reconciliation by bringing the conversations to the territory and the people being served. So I've had the privilege of speaking about health outcomes for Indigenous people on a number of occasions. I often open with this image, and I end by asking the question, are we going to put on a theater of reconciliation, or are we going to meaningfully bring reconciliation to our operating room theaters? So this painting is by celebrated Cree artist Kent Monkman, and it's a satirical take on a well-known Robert Harris painting from the 19th century. So Monkman has inserted his alter ego, Miss Chief Eagle Testicle, into the picture, and he's posing her nude before the Fathers of Confederation. Miss Chief plays the role of a trickster, and that's a mythological character who often overturns the established order, and often in a humorous way. And here, Miss Chief is subverting political history by imposing an Indigenous queer presence on the origins of Confederation. So this depicts a moment in history when the fundamental governance structures of Canada were established, and it represents when colonialism was enshrined in our systems of government. So 8 years ago, in 2015, the Truth and Reconciliation Commission passed their final report, and they heard testimonies from over 7,000 witnesses over 6 years. The Truth and Reconciliation Commission defined reconciliation as the process of establishing and maintaining a mutually respectful relationship between Aboriginal and non-Aboriginal peoples in this country. The TRC went on to say that in order for reconciliation to happen in Canada, there needs to be an awareness of the past, an acknowledgement of the harm that's been inflicted, atonement for the causes, and action to change behavior. This is fundamentally about relationships. Okay, it's a moment here for a very fast history lesson. I'm going to give you about 500 years of history in about 2 minutes.
So what went wrong? It wasn't always like this when we started down the path. When the settlers first arrived, the natives welcomed them and helped them out. It wasn't like they showed up and the natives said, uh-oh, there goes the neighborhood. And the relationship grew stronger, fashionable even. Remember these? It's a beaver hat. This was considered cool back in the day. That's right, our rodents were all the rage in 17th century Europe. That led to the fur trade, and of course the fur trade gave us Canada. For a time, the Aboriginal people had this warm and fuzzy feeling, love and understanding. We documented that in wampum belts like this one that depict two canoes traveling down the river in parallel paths, neither one interfering with the other. It's cute, eh? And the English and French, well, for their part, they signed all sorts of big agreements with great seals. Ever since the Royal Proclamation of 1763, there's been banner promises like, the natives will not be molested. Or my personal favorite, the Queen's promise to the Cree of bounty and benevolence. You know, we Aboriginal people thought we were getting a seat at the big table. But it turns out we had a reservation at a much smaller table, out the back, near the garbage cans. At the big table, they got Canada and all of its bounty. At our table, a total lack of benevolence. We got the plague, a plague of whiskey, and our parents and grandparents were molested in schools designed to kill the Indian in the child. So where did all of that go wrong? Well, step into my office, grab a seat on the big couch, and let's talk.
Okay, my apologies there. That video didn't come quite through. So that wasn't, if you want to look that up, it's actually quite easy to find. That's not Rick Mercer with a wampum belt. And that brief history lesson was given in a Rick Mercer style by a very young Wab Canoe who just last month was elected as the 25th Premier of Manitoba. So I want you to think about the different kinds of relationships that you've experienced. These lines of closeness take on a variety of shapes over time through different relationships. Your best friend in childhood is very different from your buddy at college. Relationships with family members or intimate partners take on different shapes depending on the life stage or timing. Closeness with a care provider or a pet can be very intense for short periods of time. Now, I want you to visualize what the lines of closeness look like for Canada with First Nations, Inuit, and Métis people. As we look back on 500 years of history, the lines of closeness between different organizations and Indigenous peoples have taken the shape of many of these lines. Honorable Murray Sinclair is a retired judge, former senator, commissioner of the TRC, and currently the chancellor at Queen's University. He summarizes what reconciliation means. It essentially comes down to the concept that I want to be your friend and I want you to be mine. What does your line look like when it comes to relationships that you have with Indigenous peoples? What does Canada's line look like? How about your hospital? And what will these lines look like in the future? That is fundamentally what we were talking about. So I'm going to provide some detail on what's contributing to the space between us when it comes to health and healing. Now, there's no shortage of reports, inquiries, commissions, recommendations, and calls to action when it comes to the inequities experienced by Indigenous peoples in Canada. In the last 8 years, we have seen the Truth and Reconciliation Commission with 94 calls to action, only 13 of which have been accomplished so far. The Murdered and Missing Indigenous Women and Girls Inquiry has 231 calls for justice. The Brian Sinclair Inquest in Manitoba has 63 recommendations. The In Plain Sight review here in British Columbia had 24 recommendations. In Quebec, the Vey Inquiry provided 142 recommendations, and the Joyce Echaquan Inquiry had 12 recommendations. These are not one-offs. They're not coincidences. So I'm going to allow me to provide some insight into one of these inquiries. So in June 2020, claims surfaced about a Price is Right game being played in British Columbia emergency departments, where healthcare employees were openly guessing the blood alcohol levels of First Nations and Métis patients. As a result, the In Plain Sight review was launched to address Indigenous-specific racism and discrimination in the healthcare system. More than 600 people shared their experiences. The review found widespread Indigenous-specific stereotyping, racism, and discrimination that limits access to treatment and negatively affects the health and wellness of Indigenous peoples. This was disproportionately experienced by women and girls, and it was exacerbated by the current public health emergencies like the pandemic, the COVID pandemic, and the opioid crisis. They found that Indigenous healthcare workers face racism and discrimination in their work environments, and that the current cultural safety programs to be completely inadequate. They found that Indigenous health practices and knowledge are not integrated into the healthcare system in a meaningful way, and the complaint system does not work well for Indigenous peoples. The system also lacks the governance structures, data collection, and reporting systems to act on the findings. So a stark example of the quiet racism is told in the story of two boarding houses. So these two stories were just a few months apart. Last April, a tribunal heard all kinds of BS reasons why the Inuit medical boarding house called Larga House could not happen in an Ottawa neighborhood. Local citizens described concerns about loitering, drug addicts, potential effects on traffic, and even water pressure. In my 10 years in Ottawa, I have yet to see a single Nunavut license plate. One community member actually had the audacity to say that they were here first. Even the headline frames the situation from a colonial perspective. Then, in August, just a few months later, federal ministers and members of parliament couldn't line up fast enough to the podium to announce the expansion of the Ronald McDonald House without a peep from the local community. Ronnie McDonald didn't create any tension. There were no concerns about drugs, loitering, traffic, or water pressure. These are fundamentally the same facilities with one big difference: who they serve. It is fair to say that Indigenous peoples are tired of describing the systemic racism that prevents us from achieving the same baseline outcomes that the rest of Canada enjoys. If we want to deliberately design a system to disengage, disempower, and emasculate a people, the current approach is a very good prototype. We just may have to break the system in order to break the cycle. So to date, limited data is available on the surgical and postoperative care involving Indigenous peoples in Canada. Our research group decided to address this question. So most commonly, research involving Indigenous people is done by non-Indigenous scholars. What was unique about our study was that we had representation from First Nations, Inuit, and Métis peoples on the research team. Nadine Caron is celebrated as Canada's first female general surgeon, and Donna Mae Kimilarjuk is Canada's first Inuk cardiac surgeon. The purpose of the systematic review was to examine the existing literature on information on clinically available outcomes for Indigenous peoples having surgery in Canada. We systematically reviewed 1,100 articles that included 28 studies, eventually included 28 studies from 1989 all the way to 2016. All the studies used observational designs. Of the 1.9 million participants from all included studies, about 10% identified as Indigenous using a variety of methods to determine identity. Of all those papers, we found only 5 studies from 7 cohorts that were suitable for a higher level meta-analysis. Our main finding was that we identified an adjusted 30% increased risk of postoperative death for Indigenous peoples, as well as higher rates of complications, including postoperative infection and hospital readmissions. Indigenous peoples also appeared to have lower utilization rates of both elective surgeries aimed at improving quality of life, such as joint replacements, as well as potentially life-saving procedures such as cardiac surgery, transplants, and cesarean deliveries. Postoperative complications were found to be higher in Indigenous peoples. After cardiac surgery, we found higher adjusted rates of infectious complications such as pneumonia among First Nations people. Kidney transplant recipients were about 1.5 times more likely to experience graft failure. And after cholecystectomy, First Nations identity was associated with a 1.5-fold increase in the odds of hospital readmission. We also saw big differences in the rates of surgery and wait times. So in people with cardiovascular disease, the access rate for angiography was strikingly lower at a rate of cardiac surgery being just 30% of the general population. Indigenous people with end-stage renal disease received transplants at about 1/3 to half the general population, and the wait times were longer by 3 to 7 months. Among patients who have osteoarthritis, Indigenous peoples had about half the rates of hip or knee arthroplasty. So in our systematic review, we actually found no studies that were specific to Inuit or Métis. So we decided to partner with Nunavut Tungavik Incorporated, the Inuit representative organization for the Qikiqtani region or the Baffin region of Nunavut, to answer the question about surgical outcomes for Inuit from Nunavut in our hospital in Ottawa. Now, the care pathways for Nunavut Inuit are complicated. Depending on where a community is located, the referral hospital can be either Edmonton, Winnipeg, or Ottawa. So we've normalized a system that focuses care thousands of kilometers away from home. But it's the equivalent in terms of distance, climate, language, and cultural shock for someone from Toronto to receive their elective and emergency care in Mexico. Now, there are advantages and disadvantages to this approach. I'm alive today because the system saved my life as an infant. I was born in the Northwest Territories, and I had a life flight to Edmonton for emergency surgery not long after birth. So our study was published last spring in CMAJ Open. We identified 99,000 episodes of inpatient surgery over 7 years at the Ottawa Hospital. About 1% of cases involved Nunavut Inuit. There were differences in the patient populations. So Inuit were 8 years younger. They had lower rates of diabetes, obesity, and peripheral vascular disease. Inuit were found to have higher rates of COPD, alcohol use, heart failure, and electrolyte abnormalities. The procedure mix was also different. More Inuit cases were urgent, and there were proportionally more orthopedic, thoracic, plastic, and dental procedures, with fewer vascular, urology, ear, nose, and throat, and gynecologic procedures. Now, we used a different metric than what we used for the systematic review. Our primary outcome was a composite of major complications, including death at 30 days. So 17% of Nunavut Inuit died or had a complication, compared to 16% without Nunavut Inuit identity. Now, that's only a 1% difference. However, after adjusting for age, sex, surgical specialty, risk, and urgency, Nunavut Inuit were 25% more likely to experience a major complication. And this association was even more pronounced in elective cases at 58% and cancer cases at 63%. The reasons aren't completely sure, but it certainly tells us that we need to do everything we can do to optimize health prior to elective surgery. What was fascinating, though, was that there was actually no differences found in outcomes for emergency cases. In terms of secondary outcomes, we know that Inuit experienced about a 40% increase in readmission, and the rate of discharge to a long-term care facility was over 2-fold higher. Inuit stayed in hospital about 2 days longer, and that resulted in some higher costs. It suffices to say that the results were expected, disappointing, and consistent with what is reported in other high-income countries. If I had to sum up in one phrase, it would be that we need better data, and the limited data that we have tells us that we must do better. Indigenous health research can support reconciliation if it responds to the Truth and Reconciliation's calls to action and uses the United Nations Declaration on the Rights of Indigenous Peoples as its framework for relationships. There is a role for non-Indigenous health researchers in Indigenous health research, particularly if they're willing to understand their positionality and become active disruptors of systems of whiteness and racism that are at the roots of current harms to the health of Indigenous peoples. Indigenous leaders and community voices need to be at the center of the conversation because they are the experts. This means that any research project starts in the community. It does not mean that researchers find an Indigenous partner to join what they're already doing just to help them get funding. ITK, Inuit Tapritkaitani, is the Inuit representation organization for all Inuit in Canada. And they've laid out the path time after time. 5 years ago, the National Inuit Strategy on Research was released, and it provides a roadmap for respectful engagement. Now, our study was a snapshot in time that only further describes the problem. If we want to test interventions, then we need to continuously measure outcomes against novel solutions. It turns out even today, in our data-driven world, when it comes to healthcare, First Nations, Inuit, and Métis peoples are very hard to count. Territories, provinces, and hospitals don't track rights-based data on health outcomes. Studies are often use surrogates such as self-identification or postal codes to identify Indigenous peoples. It's like we're driving in the dark at highway speeds with the lights off, and we can't even tell that we're in the ditch. It's a see no evil, hear no evil approach, and it's just come to be accepted as the normal way of doing business. The COVID pandemic has shown that we do have the capacity to develop new monitoring systems and live outcome dashboards to provide feedback on our successes and failures. We began to see some examples of using rights-based data during the pandemic when some provinces started reporting COVID infection rates and hospitalizations according to ethnicity, which provided a glimpse into the existing structures and policies that are failing populations that we choose to marginalize. There are opportunities to use rights-based data collection and transparency to guide policy decisions. We just need to apply the right carrots and sticks to encourage the health systems to act. I'm talking about money. Nothing gets a hospital CEO's attention faster than the threat of losing funding. Currently, Indigenous health policy in Canada is made up of a complicated patchwork of policies, legislation, and agreements that delegate responsibility between federal, provincial, territorial, municipal, and Indigenous governments in different ways in different parts of the country. If we're going to meaningfully address outcomes, we need to be able to measure our successes and failures. There's a need to develop standardized national monitoring of health access and outcomes for Indigenous peoples and rural and remote communities through culturally appropriate methods. I see that we're going to continue this conversation tomorrow with experts like Anne Forsyth, Ewan Affleck, and Marcia Anderson. You see, colonization is a living thing. It's what we've all learned to accept as a normal way of operating. It's baked into everything we do. We have to remain cognizant that reconciliation is not an Indigenous problem. It's a responsibility for everyone. Non-Indigenous leaders must take that responsibility for this process. Her Excellency, Mary Simon, Canada's first Inuk Governor General, said that reconciliation is not one act, and it does not have an end date. It is a process we build on, piece by piece. It's a path that we walk together, all of us. Murray Sinclair explains that you can remove all the racist people in a system, and the system will perpetuate racism because it's functioning based on policies, priorities, and decisions that direct how things were done that comes from a time when racism was very blatant. He goes on to say, we have described for you a mountain. We've shown you a path to the top. We call upon you to do the climbing. So I ask you today, are we willing to walk together to do the climbing, or will we continue to put on a theater of reconciliation? Miigwech, merci, nakamik.
Wow, thank you very much, Dr. McVicker. That was very, very, how do you call it? Exciting on one hand, because it gives us some things to hang on to that we can do, and also a little bit depressing about the research. But also, I think you end with a challenge, and I think we all need to take up that challenge. Okay, so anyways, let's get to the questions, and let me see. We have one. Amazing presentation, Dr. McVicker. Deepest thanks. What does rights-based data collection look like?
Well, it starts in the community. I think data is a very powerful thing. It is something that we can use to make decisions, to guide policy, to tell us what we're doing right and what we're doing wrong, but can also use to perpetuate further harm. And so we need to be very careful about what personal health information data we collect, how we collect it, that it's done in a respectful manner, and that it follows the OCAP principles in terms of ownership. You know, that the data is fundamentally owned and managed by the people who it belongs to. And so we need to be able to ensure that it's managed successfully. And I think you've got an entire conversation tomorrow or later on that is going to dive into exactly what that means. Ewan Affleck knows about that. Marsha Anderson was behind the using identified data in Manitoba during the pandemic, and you actually have some of the leading national experts on this subject coming to speak to you very shortly. So I'm very impressed with the people that you have brought together in this conference.
Awesome. We are so excited also. This has been just such a invigorating session. I'll just say a couple words before we go to the next question, but in Saskatchewan, we're at the point where we are considering collecting the data. And we know there's a lot of controversy around collecting it, as we've heard from everyone. And CIHI has proposed a massive collection of, you know, demographic data from all people as a way to kind of lessen the impact on collecting only Indigenous-based data. So what are your thoughts on that?
I think the more that we know about the populations we serve, and the better that our health workforce reflects the populations we serve, the better we're going to be able to serve them. So when you ask that question, you know, what is your ethnic background, or what language do you speak? The hospital has to be nimble enough to be able to use that information to actually improve patients' care. So if I tell you that I'm Métis, you know, perhaps you automatically connect me with that patient navigator, or the menu that I'm served, I now get, you know, possibly bannock as opposed to toast. You know, there are certainly options that we can be able to do that are very subtle, that make an enormous difference in terms of being able to improve patients' outcomes. And I think that goes and that applies universally, regardless of what background you are. If I'm in Ottawa, the number of Arabic-speaking people in the hospital is growing immensely, but the frequency of Arabic translation is minimal. I mean, it's very challenging to be able to make informed decisions in your second language. You know, that the entire working language in the hospital is English, or sometimes French. It's very challenging to process all that information and then make informed decisions, or to advocate for yourself if you don't speak the language. So being able to have access to even translators or culturally appropriate norms makes an enormous difference in people's ability to get through the hospital, to make informed decisions, and get onto the path to healing.
Okay, awesome, thank you. Okay, there's another question here in regards to the challenge. Where was it? Oh yeah. How can patient groups get out of the theater and onto the mountain?
So the theater I talk about is a play on operating room theater, but we're also, I think, a lot of times that we, you get organizations that do land acknowledgements, or they'll tick a box that people have done cultural safety training, and then they'll go on to whatever meeting they were talking about, and basically it becomes performative. It fundamentally comes down to relationships. Hospitals need to put the populations they serve in the directors' chairs. They need to be on the board of governors. They need to be in management. They need to be reflected right through the organization. So we need to be able to ensure that we have pathways to support people who are from the community up into the organization. In places like Saskatchewan is 18% Indigenous. Manitoba, I think it's about 20%. I'm not seeing 20% of the healthcare force in Manitoba as First Nations or Métis.
Mm.
In terms of anesthesiologists, there's about 4,000 of us in Canada. 5% of the population is Indigenous. So in order to properly reflect the Indigenous population within my own subspecialty, you'd need like well over 200 Indigenous anesthesiologists. I know almost all of them, and I can count them on one hand. So what are we doing to be able to ensure that Indigenous students become doctors and nurses? And what are we doing to ensure that they get into the specialties in all aspects of the hospital? That we create environments so that any aspect of the hospital is safe for them to be able to pursue their career. We need to be able to change the culture around how we behave, how we normalize conversations amongst ourselves, the comments that occur in the lounge. All those types of things need to change. You can paint the walls, you can have culturally safe spaces, but a hospital is made up of the people that run the organization, that are in the organization. And if you're not addressing the culture in the institution, you're not going to make a difference. So for patient organizations, it's about having relationships with the First Nations, Inuit, and Métis organizations that exist within your community, and making sure that their voices are represented at your decision-making table.
Excellent, thank you. I think that's something that I can I can act on, because in Saskatchewan we do have patient groups, but very little Indigenous representation on these groups, as you can imagine.
The other aspect I think we need to recognize is that you talk to you look at Indigenous health organizations, Indigenous organizations, and when you look at their health steering committee, it's the same people. Right. And so if every organization is looking for representation, you're overwhelming a very small group of people. And so they need to be able to be supported. They need to be able to have, the ability to address their own priorities. And so we have to strike a balance between including representation, but not overburdening the very few people. It's a very small family in Canada. It's the same names that come up time and time again on these panels and in groups where decisions are made. And we want to make sure that the people who are currently involved, that we're not overwhelming them.
Mm-hmm. Absolutely. And I think that one of the things we're thinking of doing is having a patient advisory group, but using that as a platform for them to be transferred to the other patient advisory groups, because part of the problem is that a lot of First Nations and Métis are screened out because you have to apply. But if you're not used to the system, or you don't have that voice that's used to talking in cross-cultural situations, you end up not saying anything. So having some kind of bridge into that system, I think, was something that we are thinking about. Okay, so let's see. Any more comments, questions here? Oh, I got 3 more here. Here's a question. I find it so difficult to understand how we cannot speak with one voice in Canada. Have we not learned from the past? Yet we in Canada want to fix all other nations but avoid our own nation.
It's, I think Mackenzie referred to this in a previous presentation, but we do have to be aware of the incredible diversity that exists, particularly with First Nations. You know, the Huron-Wendat and the Haida have as much in common as like the Germans and the Portuguese. Like, you would not confuse those two people. And you wouldn't talk about, like, you know, you wouldn't talk about someone from Switzerland if you meant someone from Scotland, right? You don't use the term European when you're trying to describe someone from Spain. You talk about the Spanish. Where when it comes to Indigenous peoples, particularly First Nations, there's this pan-Indigenous melting pot. And we just kind of all assume that everyone is the same. And you have to recognize that there are thousands of years of history and rivalries and different ways of doing things, that even amongst First Nations, the incredible amount of diversity that exists in the country is astounding. Some First Nations have 500 years of contact with settlers. Others, it's only 150 years. And so the nature of those relationships are extraordinarily different. I think we need to be we need to pay very close attention to the relationships that we have, the nature of that First Nations have with each other, and that we respect that diversity.
Thank you. Those are very good words. Carol gives a note here: dispel the myths of First Nations and Inuit people. Yes, I think that's one of the things that we can do. And then another question is, thank you for this insightful presentation. Do you have any takeaways for other healthcare stakeholders like government policymakers? How can they help to shape the culture and help create environments to nurture the change we need to see?
I think we have to normalize Indigenous ways of seeing and knowing into our daily practices. We have, you know, we're a lot further ahead than we used to be. You know, June 21st, you know, National Day for Indigenous Peoples is becoming much more popular. September 30th, the National Day for Truth and Reconciliation, is becoming established as normal. But I really think that we need to engage at a higher level. You know, when you watch a news story, a breaking news story, like, I would advise leaders to, like, watch it from the perspective of APTN, like the Aboriginal People's Television Network. You know, it's a national news organization that's going to cover the exact same stories that CBC, Global, or CTV will, but they're going to view it from an Indigenous lens. And I think that we need to be able to look at those. Well, we need to be able to incorporate those ways of viewing the world and viewing problems from an Indigenous perspective, and we need to make that normal. And until the leaders are really shifting the normal way of doing business, we are putting on that theater.
Okay. All right, thank you.
Like, one of the things that I've done, I don't know if I'm sharing my screen again, but like, I threw together on Twitter, I mean, people, I guess they call it X now, but I made a QR code of, like, Indigenous leaders on Twitter that, like, you can follow, right? Like, so you got Marsha Anderson on there, you got Janet Smiley, you've got Cindy Blackstock, you know, these incredibly strong, powerful women who, you know, when an issue comes up and concerns arise, like you get their perspectives, and it fundamentally changes how you would view an issue if you can actually like listen to the voices of those being impacted by it.
Thank you. That's good advice. Okay, so let's see if there's any other. There's another one from Margaret. Does the dream need to be allowed to be planted, which we have removed? Oh, I'm not sure what that one was about. Okay, I think that is our last question. Any last questions before we go on break?
I think you have found them all. Sylvia, or if any of the other organizers have noticed a question that we've missed, please bring it forward now. Thank you so much, Dr. McVicker and Sharon, for moderating and engaging in such an incredible, insightful, as it just came up in the comments, question and answer conversation, and this very practical QR code of some thought leaders, some prominent Indigenous leaders who are currently, on platforms on X. And sharing their thoughts in response to what's happening on a day-to-day basis across Canada or Turtle Island, to help people start to shift. I love that last piece. I was of advice of shifting how we do our business every day, normalizing. And normalizing, understanding there's diverse ways of seeing and knowing from across different First Nations and Inuit and Métis, and learning about those and allowing those different epistemologies fundamentally to inform our daily practice and shift how we do business and inform how we are interpreting what's going on around us. That is how we're getting out of the theater and onto the mountain. So I really appreciated just the very conceptual and pragmatic sharing that just happened. So we have more incredible content to follow. We will be taking a short break, just recognizing today is long. Please don't go anywhere. Please come back by, we can actually probably, if you can come back by 2 o'clock, we'll take a 10-11-minute break. We will then be diving into our last panel of the day, which is Cancer Care Challenges for Remote Communities, Current Realities of Nunavut Patients. And we have Rebecca Lonsdale and Carolyn Roberts here with us live to answer questions in the moderated Q&A, and everybody else who's on the panel are either going to be presenting live or sharing their insights through recordings that they've made. So really insightful panel coming up, eye-opening for those of you who are not familiar about accessing care in the Canadian territories. So please do return by 2 o'clock Eastern time zone. Apologies to those of you on different parts of the country who are in a different time zone. So 10 minutes and we will resume with our next panel. See you in 10. And I hope you've been enjoying today's content and learning. I don't know if enjoy is the right word, but learning and reflecting on today's incredible sharing of knowledge and insight from our speakers so far. And we're very excited to prepare for the next panel. So before I start the introduction, let's just see, Becky, let's do a quick test. Is your audio and your visual working? Can we say a quick hello? And then I'll do a formal introduction. Hey, Becky.
Okay, can you hear me or?
I can hear you. Wonderful. And I can see you. Wonderful. Excellent and excellent.
This was, I'm a very tech challenged person. I'm glad it's all come together.
Me too. I'm so happy that you can be here. I think it's probably not just you. I think I would imagine that technology and connectivity is not the friendliest in your neck of the woods. So let's. I'm going to just introduce, and then I will pass the microphone and the video over to you. Sylvia will share slides. She, I think, is hopefully there are some images there. It may not be in the order that you would like them to be. So we will do our best there. You could just let her know if she needs to go back or forward, and if we need to sort of put that slide deck together again in the proper order and then share it out with everybody after the fact. We are more than happy to do that as well. Just so very glad that you can be here to share your professional and personal expertise. So let me do a quick
Carolyn
intro.
going to be presenting first, or?
We're going to start with you. We're going to start with you, and then we will share Malaya's video, and then Carolyn and Tim prepared a recording, and then we'll go to moderated Q&A where you and Carolyn will be able to respond to any questions that are coming.
Okay.
Great. So we're going to start our next panel presentation. This is an amazing oncology project between the governments of Nunavut and Ontario, and between the Ottawa Hospital and the Inuit of Iqaluit and beyond, which came to our organizing committee's attention when the Ottawa Hospital held a cancer conference in Iqaluit, to which Louise Binder of Savior Skin Foundation was invited earlier this year. And what she learned about the incredible hurdles to provide cancer care, and that's just cancer care, let alone all the other types of care that people require, in and for a territory, a community that is more remote, and the enormous struggles of community members and their loved ones in accessing these services, and when they are accessing the experiences that they have in that process. That was so eye-opening for Louise that she recommended to our Summit Steering Committee that this be part of today's program. And of course, we all readily agreed. And we're sure that once you have heard more about this story from an Inuit community member, from healthcare and other service providers who are trying to provide them and their loved ones services and achieve better outcomes for them, you will have a new understanding of the challenges for remote communities of accessing healthcare and related services in the Canadian territories. So on our panel, Rebecca Lonsdale, you will find everybody's full and impressive bios on our webpage, Patients Redefining the Future of Healthcare.ca. Go to the summit. But just briefly, Rebecca Lonsdale graduated with a BSCN in nursing from Dalhousie University with a particular specialty in Arctic nursing, and that was back in 2006. She's going to share with us from her lived experiences supporting her mother through cancer, as well as her years of professional expertise of nursing in Nunavut. We will also hear from Malaya Zaire, who's a proud Inuk woman born and raised in Iqaluit, now living in Aimler, Quebec with her husband. Malaya is the president of Larga Baffin Limited in Ottawa, Ontario, which is a medical boarding home for Inuit who travel from Nunavut for medical purposes. And we're going to hear from Carolyn Roberts, who has a 25-year nursing career, which has been predominantly in outpost settings through northern Quebec and Nunavik. In 2016, she became the Ottawa Hospital's first Indigenous nurse navigator for the Indigenous Cancer Program. And finally, we'll hear from Dr. Tim Asmus, who's a medical oncologist at the Ottawa Hospital Cancer Center, as well as associate professor and director of the Medical Oncology Fellowship Program in the Department of Medicine at the University of Ottawa. So I would love to pass the microphone and the video over to our esteemed guest, Becky.
Okay. So if there is a pause, or on your end, if it freezes, I'm really hoping a message kind of pops up. I'm very tech challenged. So mamaya na ugalawa. So yan namin lagaw tunga suchitaw guma. Uli pikaw yung anya siyo yung My name is Becky Lonsdale, and my Inuktitut name is Uripika Ilata Lonsdale Akulujo. Well, it's not Lonsdale, but it's Akulujo. And English is Rebecca Lonsdale. And just to clarify, if I sometimes speak in Inuktitut, if I'm in a concept where I need to re-explain something, it's just because my primary language is in Inuktitut, so I need to sometimes process it mentally in my language before I can verbalize it back to you in English. So anyway, just to get started with my presentation, I'm connecting with you from Iqaluit Nunavut. And the focus of my presentation, again, is the patient and family perspectives about my family journey through our oncology experience. But what you'll see in parts of my presentation too is what I experienced with navigating with both systems, meaning this would be Qikiltani system, Nunavut healthcare system, and the Ottawa Hospital Ontario system. So I'm going to go to the next slide. I'm not really seeing how this, okay. So it's very wordy, so I'm going to summarize here and there what I say, and you'll be able to read if I decide to skip through parts of the point. It's just because I know I have it highlighted in another box. So my key messages today is based on my family's lived experiences about the oncology journey from the time of diagnosis as the inpatient, then experience of the outpatient experience and part of the surveillance plan, and navigating through that as a family. It so happens that I'm a nurse with experience with navigating through systems. So part of that was also teaching my family how to navigate through both systems. And what I can tell you is even from a nursing perspective, it was difficult to navigate. And the challenges were definitely there. I think maybe because I'm a nurse and I'm a caregiver and the worlds collided, and this was hard to cope with. It's almost like ignorance is bliss, but you know too much. So parts of the Nunavut side will highlight the lack of cancer screening programs in Nunavut, the patient and family responses and experiences of accessing oncology care at a distance from home, and the implications of this on our family. This would be about emotional, mental, and financial implications. The supports that we had accessed through OSNI, through Qikiltani General Hospital, my community, and the Ottawa Hospital Indigenous Cancer Program, and the psychosocial program. So the other summaries are there, but in keeping with kind of the time provision, I wanted to be cognizant of that as well. One important concept that I'm going to talk about is difficult for me to talk about, but I'm going to do it anyway. So the response of how this experience can be very re-traumatizing to a post-trauma patient. And what do I mean by re-traumatizing? What do I mean by a post-trauma patient? So based on my mom's specific experience and with healthcare, having experienced being sent away on a ship as a young girl from our home community in Pandiltu all the way to Ontario for a year, it was about a year or more on those transfer ships for TB treatments, and entire, like, people being sent away for TB treatments and being separated from family. Some of the triggers that were involved with having experienced that type of a trauma. And this is an interaction with the health system as being forced to travel, being forced to stay in the sanitarium, being forced to travel without your family, being forced to eat food that's not our food, and understand a language that's not our language, to be introduced to procedures that are unfamiliar to us, they're not being explained to us, and responses to pain. So that when I talk about that, and I'll come back to that later, just to kind of have that sit in the back of your mind when you think of my mom as an oncology patient, I want you to visualize her also as a little girl having experienced this, okay? The last point is, what would a provision of culturally sensitive care look like within our healthcare systems and in our institutions? So some of my suggestions, maybe point of conversation. I think there'll probably be lots of discussion points for that at some point, and I'll go here to the next slide. Okay, So the images that you're going to see on that screen is what I mean. So my mom is on the far left, standing in front of the nurse where you don't really see her face. And the other families, parts of what she experienced. I want to really tell you this. She had her hair cut when she was there, and there were big rules in our culture of not to have your hair cut. And here it's really weird to see her with bangs, and that was another part of the trauma that I want you to visualize that. I want you to see that. And then, of course, happier times. She's holding me as a baby, and I'm a very cute, chubby baby. So part of the lived experience, my mom's name is Mea Akulucho. She was diagnosed as a coincidental finding. This was a year and a half ago at QGH, and it was actually, she had a follow-up for an unrelated issue. And after our initial conference up here for cancer, oncology, cancer care conference, those statistics that were communicated to our providers from the Ottawa Hospital about our tremendously high rates of lung cancer, especially amongst our women, Inuit women. Some of our GPs started to screen for lung cancer with low-dose CT scans, even if they were, and they had to have met like a certain criteria, even if it's not official. This was something that was being practiced shortly after that conference. And before I had advocated for that, he had already actually done it, her doctor. And it showed a nodule, coincidental finding, a small nodule in her left upper lobe. So that actually was not the primary. We started this journey with the Ottawa Hospital. So being referred to oncology at the Ottawa Hospital, this takes a month. This is not something that happens within a week. There's a process that occurs, and I know there's wait times, and we're also in Nunavut, we're not in Ontario. Some of the specialized scans, these are not available here. So we have to travel to get a PET scan. We have to travel to get an MRI and a bronchoscopy. We have to travel to get chemotherapy and radiation treatments. Although chemotherapy drugs, some of them are being offered now here in our territory. Very new development. So this month-long process begins, series of scans, PET scans, bronchoscopy. And although the treatment plans and the inpatient part of it was incredibly difficult, some of the challenges that were there is if you're going with someone like my mom who has a basic English comprehension, the translating part of medical terminology in itself is very challenging. It's easy to lose the details and the implications on your life. I'm going to go to the next page. So when we're getting a little lost in my train of thought. As an inpatient for my mom, some of the supports that were offered to us were really amazing. And even though you kind of feel like you're overwhelmed and coping, you're not maybe always coping. So accessing some of those supports that were offered to us through the Indigenous Cancer Program and the psychosocial program, this really feels like a safety net. It felt like a safety net for me. I had a safe space to go to in a community room, to get off the floor, not hear the bells. I had a hard time eating in front of my mom because she had a low appetite and a new ileostomy. So when I say safety net, I seriously mean that there were days where we're struggling to cope, and I just, as a caregiver, was exhausting. So I needed that. So I had that. I wish there was more of that. I wish there was a green space. I wish there was a bigger quiet room. I wish there were so many things on my wish list. I wish our food was accessible through the hospital. So when I go through and I use things like accessing that type of support, what did that look like? That was psychosocial. That was very mental health. That was like support, hold my hand, let me cry, let me be angry, let me express my frustration. I'm navigating and I'm extremely overwhelmed on some of the days. So when I look at places like that, these represent a place of peace for me, of quiet, a place that I can eat or nap. Sounds so simple. Not so simple when you're a caregiving nurse. So, and I'll transfer to the next slide. The inpatient part of that experience, it just flagged me if I'm running into a bit of a time lapse here, but some of the responses to trauma. When I talked about having been sent away on a ship being hospitalized for an extended period of time was re-traumatizing for my mom. It's re-traumatizing. There are several triggers associated with that. So when I think about the trauma and effect of trauma and how that depletes her coping skills, triggers, well, what kind of triggers am I talking about? These are smells in a hospital. They're the noises. There are procedures. There's needles. There's being given a pill. Actually taking the pill when your experience has been that those things were forced on you. You're going to associate that intervention, that medical intervention, nursing intervention with pain. So when you're being constantly stimulated like that as an inpatient, it depletes your coping skills to the point that, you know, how am I supposed to participate in my care plan? How am I supposed to learn how to deal with this ileostomy? How am I supposed to cope with this pain every day and actually get up walking as a post-operative patient? So much to focus on, but this constant trigger is happening. How do I do this? So it was nothing short of gracious when I say I was there to support her through this. It was really her that made the effort to work through all of that. So imagine that would be a common experience amongst many Inuit and many Indigenous peoples. Receiving health information in English, coping with triggers, separation from family and being away from home and not speaking my language every day, even that for me was also another triggery kind of thing, but it was lonely and it was isolating and it was difficult. There were some good days and there was always bad days, but there was also good days. The responses from the trauma for Inuit can affect the pain assessment. So if you're looking at a post-trauma Inuit patient and they're being constantly triggered and now they're having a pain response, how do you decipher a pain response from a trauma response? This makes the pain assessment incredibly difficult. Those pain scales do not work for Inuit unless you have a very clear numeric understanding. The numeric part, give me your pain from 1 to 10. I would think that as in currency, number of animals, or how many. It doesn't describe and it doesn't support describing the intensity of the pain. How does this affect your sleep or appetite would be better. How is this affecting your daily activities? Can you get up to the bathroom? You know, are you withdrawing from your daily life? You know, these are very more effective pain assessment, not just the physical part, but how it's affecting a person. So that's an example of what I mean when I say routine pain assessment using numbers. And that's what I was trained to do in nursing school. How I completed a pain assessment in my practice later changed. And that's what I ended up using. And that's what I'll use to this day. Okay. The other stuff, Leah, I'm not sure if for Nunavut healthcare or the rest of my slides if I have time, but accessing oncology services in Ottawa and Osney, we have to travel for most of our appointments, but we also access virtual care. Okay, we also access virtual care, which means the oncologist can call my mom at home and we can attend with her on speaker. We can do this, and it's like Skyping. We can have a telehealth appointment. This avoids travel. Still can hear them, still receiving information and results of a scan in a more timely manner, and virtual happens to work for us. It does not going to work for everybody. Not everyone has a home phone. Not everyone has a cell phone. Sometimes in a community further on Baffin Island, people have to come into the health center to speak to their oncologist like this in a telehealth format. So it's accessible. It's not always the easiest thing to organize the further north you go. And it always is going to depend on the autonomy of the family, just because internet connections are also, they're harder, but food security, insecurity is so high, cell phones are not going to be a priority for a family. Accessing affordable plans is not going to be a priority. So a lot of times the healthcare center is going to have a larger role in accessing virtual care if you're further north, say outside of the core where our hospital is, and you're in a more isolated community. The continuity of care, that's always the more difficult one, especially for surveillance type patients. How is a person who requires a scan and they're in North Baffin, they come here to Qalu to have their surveillance scan every 3 to 6 months or annually. The results are now sent to the Ottawa hospital. How is all of this information communicated? How does the care plan work? So you're looking at chunks of time in that surveillance plan that has real potential to extend unnecessary times. So you're looking at timelines, you're looking at how communication affects receiving those results and actually getting an appointment. So when you're looking at our systemic obstacles and our systemic challenges, those are very real logistics, but there's also so much room for improvement. Screening programs that are work in progress. There is a colon cancer pilot screening program in Nunavut, and that was, I think, in 4 or 5 communities, but I'll have to maybe really verify. And the nature of my presentation isn't so much on the operational side, it's very much on the caregiver side, but I can always comment on some of the stuff. We don't have a formal lung screening program, although the practice is changing. This is going to be formalized sometime maybe over the next year or 2 as our oncology partnership grows with the Ottawa Hospital and QGH in our region. Breast cancers, this kind of stuff. So just to be super clear, QGH, maybe I should have communicated this. We're a regional hospital. We're the only hospital in the territory. We have a surgical service. We have a blood bank. We have a CT machine. We have an ultrasound tech and a lab. And we have there's more resources. These resources will not be available to you from a health center. The health centers they don't have a blood bank. They don't have a full-time doctor. These are run by community health nurses. You have access to X-ray and your iStat, for those that understand the world of iStats. Their labs are sent here to our lab, other than the emergency stuff you might do on an iStat. So yeah, the QGH cancer care, I want to be clear also that our cancer care considered QGH started out as a much larger team. We're now down to 2 physicians that rotate into that. There's other doctors that maybe are going to begin to rotate into that. This is more of an operational thing, but the developmental side, developments of our cancer care programs to offer more infusions at our hospital, that's under development. And we want to offer care closer to home so people don't have to travel such a distance for their infusions. This is very infusion specific. This is not about radiation. So just to be very clear about that. And I think I'll go to the next slide. In summary, the culturally sensitive care part. So I teach about this. I teach about how to provide culturally sensitive care, but this was more in the world of obstetrics and neonatal care and that kind of stuff. So thinking about cultural orientation and continued learning, one thing that needs to be built into this is that it's not a one-off orientation. Now I've been oriented to this culture. There needs to be more sincerity that's more interactive, the continuation. The continuation of the learning is actually a spectrum, not a one-time orientation class. Provision of language services in our institutions, expansion of patient learning tools, so being creative, being informative, being more visual. Specifically, when I'm talking about language and access to these types of terminology, they're very specific terminology to learn in my language. It's not easy to learn it, but it's learnable. Things about procedures, tests, scans, diagnoses, and communication skills. The cadence of your speech, the content. So you want to be simplified but not dismissive. And you don't want to speak to patients as if unless you're speaking to a child, but you don't want to speak to adults as if they're a child. Just because I'm unilingual, does not mean I can't understand the complexity of what you're communicating to me about my body, about the treatment plan. So just because there's a language barrier, don't make the assumption that it's too complex to be translated. It's not. That makes it seem like Inuit can't understand, and we can. The production of healthcare professional type tools like pictograms really helps bring the entire communication piece together. So those images of what does a PET scan actually look like? What does this gallbladder and this lung part, this is where that is, and this is where this procedure was. It brings the visual piece together. So I'm a big fan of those. And safe spaces, green spaces, places to rest, places to eat, places to pray. We need more of those in our institutions. I think even though efforts are made in many institutions, and I can see a shift in our society of how do we create more culturally sensitive spaces? How can we create more Indigenous spaces that are relevant to us? You can only institute them if you consult Indigenous people, if you consult Inuit people. This is my opinion of how an institution can be more inclusive, be more sensitive. And I'm one person. I don't know how, the common population would think, but I think there would still be an agreement that we still need a place to belong. We still need a place to sit in peace. And those would typically be a quieter space, a nature space, or a green space. So anyway. I'm going to stop there. I've taken so much time. I'm very sorry. I don't want to eat into other presentations.
Please don't apologize. That was wonderful sharing, and we're deeply grateful. We will now move to a recording, so just give us 1 second, of Malaya Zaire, who is the Executive Director of Baffin Larga, and you will learn more about her and Baffin Larga in just one moment. Bear with us as my colleague Sylvia brings the video up.
Ulakut, good morning. My name is Malaya Zaire. I am the president of Larga Baffin Medical Boarding Home here in Ottawa, Ontario. I will get right on to the presentation here entitled Meeting People Where They're At, Modernizing Healthcare to Meet the Needs of All. Who is Larga Baffin Limited? Larga Baffin Limited is a medical boarding home facility for Inuit traveling from the Baffin-Qikiqtaalni region of Nunavut for medical services not available in their home communities. Some of the medical services include going to the Heart Institute, getting cancer care treatment, chemotherapy, eye care center, neurology, CHEO, etc. Our shareholders include Qikiqtaaluk Corporation and Nunasi Corporation. Our services include accommodations, meals, transportation to and from the airport, transportation to and from appointments. This is what the patient journey looks like. Patients are seen by the doctor in their home communities. OSNI referrals coordinators makes appointments to see the doctor in Ottawa. Then the medical travel books patients' travel. It is determined at that time if the patient requires an escort, and if an escort is approved, then they travel to Ottawa via Iqaluit Nunavut on their way to Ottawa. Patient and escort are then booked to stay at the Larga Baffin Medical Boarding Home. Patient is then sent to the hospital or to their specialized appointments that could take as long as a few days, weeks, months, or even years. Just to show you some of the pictures of our clients and what Larga Baffin facility looks like. We had a Nunavut Day celebration this summer. You could see all the people on the right side. We had a lot of fun. Our culture, country food. Many households in Nunavut consume country food such as Arctic char, caribou, seal, whale, clam, seaweed, and berries. Every part of an animal is harvested, is shared, and every part is used in one way or another, i.e. by making clothing. Nothing is ever wasted. The community typically comes together to have a feast and share with one another. The food we eat is a delicacy to us, the same way you love and enjoy steak, seafood, sushi, and so on. We too enjoy our kwak, frozen country food such as caribou, Arctic char, beluga, and so on in the same way. On here you see a set of ulus. An ulu is an all-purpose knife that is typically used by Inuit women, and they are used for skinning animals, cleaning animals, cutting up country food, and so on. And the middle picture here is a kullik. Kullik is source of heat, for source of light and heat and used for cooking. And the fat in the whale blubber or the fat in the seal can be used to light the kullik. For, again, heat and source of cooking. Most events held today use kullik as a source of opening or typically followed by an opening prayer. Client and escort challenges, leaving family behind for extended periods of time, financial burden and struggles, no family supports during most difficult health journey. Example, being diagnosed with an illness and not having family supports. Not all family have escorts to support them through their journeys. No support are available via counseling, social worker, mental health supports. So those are very much needed supports for our clients. As well, struggles with substance use, alcohol, tobacco, drugs, and so on. Our language, Inuktitut, Inuktut. Many Inuit speak Inuktitut, Inuktut. Many still use the writing syllabic system. However, the use of Roman orthography, the English version here in the middle, has been adopted in 2016 in hopes of saving our language. The syllabics writing system was developed by Christian missionaries to write the Bible, hymns, and printed text to Inuktitut. Syllabics here on the left. There are many dialects across Nunavut. There are differences in pronunciations between communities and regions. There are many Inuit who travel for medical that are unilingual and therefore must utilize the medical interpreters for their appointments. The medical terminology can be very complex as it is, let alone trying to communicate complexities of diagnosis and treatment plans. The process, the journey. For those of us in Ottawa, we take for granted that we can typically get a doctor's appointment within days. What we don't realize is that our clients have to travel thousands of kilometers to Ottawa with a stopover in Iqaluit for days, weeks, months on end for their medical appointments. Then they have to be housed in unfamiliar homes. That is not their home. But we're very fortunate to have Inuit-specific medical boarding home where they can stay with us at Largabaffin. Example, for many, it is their first time in a city of 1 million people, coming from a small community as small as 389 people. Talk about a culture shock. Driving in a transportation going as fast as 80 kilometers an hour. Most communities' maximum is 20 kilometers an hour. And those buildings, many buildings, and how far everything seems, even inside the hospitals. And oh, those trees. Nunavut has no trees. So when you think about the process of coming from their communities to Ottawa, it can be a culture shock. How can patient organizations help? If the services you provide affects our Inuit clients, communicate, educate what those services are over and over again. Have a presence in our facility to speak about your services, hire an interpreter or translator for your documents. Majority of our clients speak Inuktitut. There are some that are unilingual. Think about how this can be done in the simplest way. Western medical services is already very complex as it is. Nakokmi, thank you. If there are any questions, please feel free to send them my way. Thank you.
So I think you'll see how Becky and Malaya's presentations and what they're sharing complement and also build on each other. And we have one more video that we'll be sharing, which is prepared by Carolyn Roberts and Dr. Tim Asmus, who are both providers at the Ottawa Hospital, working with these patients as part of the cancer care program. So just bear with us for one moment as we bring that video up. and share it with you. And then we'll move into our moderated Q&A. We're very lucky and fortunate and grateful to have Becky and Carolyn here with us to answer questions. I see some are already coming into the chat, so please don't hesitate and add your questions into the chat or into the Q&A box, and we'll bring them up after we hear from Carolyn and Dr. Asmus.
Well, hello, everyone, and thank you for inviting us to speak today on the very important topic of cancer care for Nunavut. Our apologies for not being with you live right now, but thank you for the organizing committee for inviting us to create this recording about this very important topic. So, my learning objectives for today is to review the epidemiology of cancer in patients from Nunavut, review treatment and outcomes of cancer patients from Nunavut, and review the quality of improvement initiatives between Nunavut and cancer centers in southern Canada. So I always like to introduce this topic with looking at this map of Canada. And for us who live in the south, you know, most of us live within 90 miles of the United States border, but of course Canada is much bigger than that. And this slide shows all of the communities in our territories, and particularly for the focus of this conversation is on Nunavut. And the red lines represent the traditional air travel routes of where people will travel to come to the cities in the south, and particularly if they have a serious diagnosis such as cancer. And as this map illustrates, the distances are immense. And just by looking at this map, we can realize that if someone has to travel this distance for the workup and treatment of cancer, that is a very long, arduous process. It is, you know, takes someone away from their home communities for usually a lot of time, and it really is quite difficult. So this headline in the National Post from a few years ago really caught my attention, and I think really caught the attention of every oncologist in the country, and that is Inuit who were once relatively cancer-free now have the highest rates of lung cancer in the world. And the people of Nunavut have known this for quite some time. The article that I just showed you, I believe, was from 2016, but I found this local news paper from 2013, where the people of Nunavut knew that, even 10 years ago, that they had the highest cancer death rate, really, for the last decade. And these headlines really came from this key research that Dr. Young, and who is from Edmonton, Alberta, as well as his international colleagues who study circumpolar populations, really were able to define. And on this slide, it shows that the red bar at the far end of the slide represents the age standardized incident rates of lung cancer in males in the 10-year period between 2000 and 2009. And the people of Nunavut on this slide have the highest rates of lung cancer in males in any of the circumpolar countries. And what's unique about Nunavut is that this very high rate of lung cancer is in both males and females, as illustrated by this slide. Now, I always like to take a few minutes looking at our Canadian cancer statistics. So remember, these are statistics that are published in partnership with the federal government as well as the Canadian Cancer Society, and really gives a snapshot about the burden of cancer facing each of the jurisdictions of Canada. And on this slide, it shows that Nunavut continues to have the highest cancer mortality in Canada. So the darker the blue, the worse the outcome for people in that region. And unfortunately, Nunavut is the darkest shade of blue on this slide. And I would like to read a portion of what they say in the Canadian cancer statistics. And that is this statement that differences in cancer mortality rates may correlate with differences in the incidence due to regional variation and modifiable risk factors, as well as differences in access to cancer services such as screening, diagnosis, treatment, and follow-up. So as a medical oncologist in Ottawa, I read this statement as, you know, a call to action, if you will, that we at the Southern Cancer Centers who provide the tertiary oncology care for patients of Nunavut really have to improve what we're doing to improve this terrible statistics, which I'm showing you on this slide. So what do we know about the burden of cancer, the epidemiology of cancer in Nunavut? Well, our team in Ottawa set out to define this, you know, over a decade ago, where we looked at all of the Inuit who were referred down to us in Ottawa from Nunavut over a 10-year period. And what we found in this retrospective chart review were the number of cancer patients who had cancer during that period of time. And we learned that in cooperation with the government of Nunavut by looking at the Nunavut Cancer Registry, as well as the patients who then made the trip down to Ottawa to receive treatment. And we were able to look at a number of variables, including how long people were down in Ottawa for, the treatment that they received, and ultimately their outcome in terms of survival. And what we found was that the cancers that we see in Nunavut are different than the cancers we see in southern Canada. So the most common cancers over this 10-year time period were lung cancer, colorectal cancer, and nasopharyngeal cancer, which, as a Southern Canadian oncologist, when I think the common cancers, I mainly think about breast cancer, prostate cancer, and then lung cancer and colorectal cancer. But we really see a difference in the cancers that the people of Nunavut experience. What we also found was that the age of getting cancer is probably 10 years younger than what we see in southern Canada. And interestingly, we saw more women than men being referred down, almost by a 2-to-1 ratio. This slide shows all the patients who had cancer over that 10-year period. And what we found there was 374 patients in Nunavut who had cancer during that time. 286 of those patients were referred down to Ottawa for assessment. We found that 216 of these patients were Inuit. And then this slide shows all the treatments that people would come down and get, either definitive cancer treatment or palliative treatments. And that involved a wide range of treatments, including surgery, radiation, and chemotherapy. And in terms of outcome, this is what's called an overall survival curve. So it shows the number of people who are alive at a certain time point after their diagnosis. And during that era, and this is for lung cancer, this survival curve is somewhat similar, we would say, to what we were seeing in southern Canada. So our conclusions from that were that of the people who would come down for treatment in Ottawa, they would receive appropriate therapy, and their outcomes were fairly equivalent to what we would see in a Southern Canadian cancer center. But as I mentioned, interestingly, we saw this gender disparity in access to oncology care. And, we were seeing between 2 and 4 times the number of women to men who are coming down or who are accepting therapy. And for these cancers that we see from Nunavut, we wouldn't think that there is a difference in the gender. Usually there's not a difference in the gender with lung cancer and colorectal cancer and other GI cancers. So is there something going on where we're not making enough diagnoses with men, or for whatever reason, the males are not coming down to Ottawa to receive the appropriate cancer care. So our study, did get a fair amount of media attention when it came out, and I talked to CBC. I gave an interview going over the work we did and the collaboration we had with the people in Nunavut, and this is the headline that they came up with after that conversation, and they really honed down on the finding that approximately 30% of patients in the Baffin region were not did not come down to Ottawa, and there's many reasons to explain that. But it's one of these problems when you do research. It's hard to do research on patients that you don't meet, and so we couldn't really ask people why they weren't coming. But definitely is something for future work to figure out who these patients were and why they didn't come down to Ottawa. So so that was kind of 2000 to 2010. How many patients are we seeing these days? We've been keeping track of this on an annual basis, and our numbers seem to be going up. And so between 2014 and 15, we saw 145 patients, and it looks like that number goes up by about 10% per year. And in fiscal 2022, 2023, we saw 200 unique patients in Ottawa, with a total of 2,000 visits. And these are just numbers and statistics, but you can imagine that for each one of these individuals, this is a trip down to Ottawa. These 2,000 visits, are we doing these visits once a month? Are people having to come from their communities and making this long journey that I showed on one of my first slides on the map? So really, there's, these are just numbers, but there's, such a human side to the story behind these numbers, and the vast distances that patients are coming to receive the appropriate cancer care. We saw about 60 patients in the most recent year receiving systemic therapy in Ottawa. So that just gives us a bit of a ballpark to look about how many patients in Nunavut or the eastern part of Nunavut would require therapy. Of course, with these distances that patients are traveling, if we could envision or plan a program where we could treat people closer to home, this number is probably going to be much higher, once you start to remove the barriers of travel. So these are the cancers we're seeing more in modern times. So you can see on this pie chart, most of the cancers are gastrointestinal cancers, with the second most common cancer is lung cancer. So what about the future? We've been talking about this with the team in Nunavut for quite some time, and certainly there's lots of things that we can do, and I'm happy to report that currently we are working on really all of these. And the role of virtual care, we saw this during the pandemic, that this really did gain acceptance. Routinely now we're able to offer virtual care to our patients where appropriate in the territory. Access for Nunavut healthcare providers to our weekly multidisciplinary cancer conferences. Patients traveling during treatment. So, the example I gave, if somebody needs treatment once a month, maybe they just come down to Ottawa, get their treatment, but then they can go home for a few weeks and then, make that trip back. That could be better for some people as opposed to just having to live in Ottawa for the full 6 months. What about systemic therapy delivery in Nunavut? So we're in active discussions with the team up there about how we can, get care closer to home, and hopefully we'll have more to report on that in the not too distant future. Better patient navigation, and of course, cultural and translation issues. So, as mentioned, we're working on improving systemic therapy in Nunavut. This is one of our trips up there, where we found, that the government had ordered a chemotherapy hood, but it's one of those classic examples where they ordered the chemotherapy hood before we had a program. So I don't think this machine was ever used. I think it's actually out of date now. But one piece of equipment is not equivalent to a comprehensive, systemic therapy program. But certainly the team up there is working really hard now to hopefully create this capacity for the people of Nunavut. And what about diagnosis follow-up in the territory? Well, of course, Iqaluit has its own CT scanner. It's an excellent scanner. The images are beamed via satellite up to our system here in Ottawa, where it can be reviewed by me if they're my patient, and our radiologist here in Ottawa. So that's been a real bonus. And just this past spring, we were able to bring over 70 people together for the very first Cancer Care for Nunavut conference. We called it Working Together for a Common Cause. And really over this 2-day period, we were able to cover a lot of material about how cancer affects the people of Nunavut, and really I think was instrumental in some great brainstorming about how we can improve cancer care for the people of Nunavut. And this is a picture about all the participants who were at our conference. So with that, I would like to thank you for your attention, and sorry again I couldn't be there in person with you today, but always available for questions by email at a later time, and I'll hand over our virtual platform to my colleague Carolyn now.
Hi, everyone. Thanks, Tim, for the introduction and that fantastic presentation. So some of the slides in my presentation may be a little repetitive, so I'll speak to it rather quickly. But the focus of my presentation is more from a patient perspective. So now, all right, so let me start. So I like to begin this presentation by starting with why positions like mine exist. So we're going to go back a bit in history. When the school is on the reserve, the child lives with his parents, who are savages. He is surrounded by savages, and though he may learn to read and write, his habits and training and mode of thought are Indian. He is simply a savage who can read and write. It has been strongly pressed on myself as head of the department that Indian children should be withdrawn as much as possible from the parental influence, and the only way to do that would be to put them in central training industrial schools where they acquire the habits and modes of thought of white men, from our first Prime Minister. So I will begin with an additional, I will additionally begin with a land acknowledgement. Here at the Ottawa Hospital, we are on the traditional and unceded land of the Algonquin people. I am from a small community of St. Paul's River, Quebec, that you see here in this slide. That is the traditional and unceded land of the Innu and Inuit people. And I encourage all people of Canada to look into the First Peoples of the land where they live. So I get asked quite a bit, what is an Indigenous nurse navigator? So it's a unique role providing 100% patient-centered care. It's land-based, trauma-informed, and culturally safe. The number one priority I have is to establish a trusting relationship. I do not replace any existing roles within healthcare, but I complement them. People, quite commonly think I'm a case manager. I work with NIHB. It is a completely independent and unique role compared to every other position in the Ottawa Hospital. So a part of what I start with whenever I give a presentation as well is First Nation, Inuit, and Métis 101. It's so often we hear the term Indigenous, and Indigenous is really a pan-Indigenous term, and it predominantly means First Nation. It is so important for each of us as healthcare providers, and I think all Canadians, to know the difference between First Nation, Inuit, and Métis. So the dangers of not knowing the difference of First Nation, Inuit, and Métis, and I am completely bipartisan when I share that, but when you are in a position of leadership within a hospital, within our Canadian government, honored to join the Algonquin elders and leaders at the Eternal Flame to mark National Day for Truth and Reconciliation. Wonderful gesture, but knowing the difference between First Nation, Inuit, and Métis, he obviously does not. All the people he is with, they are not Algonquin elders, they are Inuit, and they are Inuit, as we can see by their wearing their traditional clothing of Imantis. Another hot thing I completely was shocking to me when I first started this role is the social and economic inequities in the Inuit Nunangat. This profile is from 2018, but in their 2021 report, the numbers didn't change. And I suspect now the next report will see higher numbers both in Inuit and all Canadians, but I'll just highlight a few. So the Inuit have 70% food insecurity in all households compared to 8% of mainstream Canada. 70% are food insecure. The median income for the Inuit is approximately $23,000 compared to $92,000 for the non-Indigenous, non-Inuit person living in Nunavut. Their TB rates are 300 times the national average. So these posters is just showing the timeline that Tim alluded to. So in 1999, the Ottawa Hospital took began the relationship of being the tertiary care center for the eastern sector, the Baffin Island sector of Nunavut. This program and my role began in 2016, became fast colleagues with our oncologist, Dr. Tim Asmith, and other star oncologists we have here. And so in the context of time, I won't go into all of it, but it just shows with the dates the importance of relationship building between our team and the team in the Arctic. And in a relatively short period of time, by collaborating and working together, we were able to deliver the first ever immunotherapy in Nunavut. And again, so this is about the ongoing supportive work we're doing in the Baffin Island sector of Nunavut. So myself and two oncologists are going up every 2 to 3 months for supportive care, and continuing to foster those relationships. But in 2023, when Dr. Asmith was really the leader behind this inaugural cancer conference in Iqaluit, it really brought together people from all across Canada, and it increased the awareness of the differences between mainstream Canada and particularly Baffin Island. Most folks weren't aware until you were actually there. And so that is why I always share a little bit of the statistics and the importance of knowing the difference of First Nation, Inuit, and Métis. So with this position being 100% patient-centered, well, what does that mean? What does it mean advocating for what the patients say their needs are? I advocate for what they say their needs are, not what a provider thinks their needs should be. I could give many examples of that land-based relationship, the trusting relationship that we work so hard to achieve. But given the intensity and the very emotional trajectory of some of our patients, as Dr. Asmus shared in his presentation, I will share a video instead, and it'll really just capture a part of what I do. And I also just like to preface by saying all folks in this video agreed to participate, and they gave consent. Sorry. So in that video, a lot of the things I get in this role are bucket wish dreams. And for people living in Southern Canada, to see a horse, to swim in a pool, you know, we take things like that for granted. And when your English is not your first language, you are really in a very different environment compared to the Arctic. You know, we have to provide so much more than what goes on inside hospital walls. And when folks and people, Indigenous people from across Canada, if they're not living in the southern portion of Canada, the Indigenous people are living in remote, and the story of the Inuit is not alone. It's throughout Canada within our First Nations people as well. So another thing I always share about building that trusting relationship, you know, is very visual. And I never wore a white lab coat in this role. I did once, my very first day as per policy, and I never wore it again because it just felt so wrong. And so, like, why would a white lab coat be so triggering? So particularly, you know, in addition to all the trauma and the racism that is well documented that Indigenous people face in healthcare, but with the Inuit of Baffin Island, so in the 1960s, for about 6 years, there was a ship called the E.D. Howell that went into every community on Baffin Island. There was a doctor and a few nurses on that ship. And so every person in those communities were forced by the RCMP to go aboard that ship, where they were determined if they had TB or not. If they did have TB, they were sent to the hull of the ship. They were not allowed to go back to the community to say goodbye, collect belongings. They just went to the hull. Some never went home, and some were never seen again. So a white lab coat can bring back that trauma for the Baffin Island patients, and even the younger ones are well aware of what happened to their grandparents. So conclusions and takeaways. So Inuit people are people from the land. It's important to work with our patients and families and community to make their healthcare services culturally relevant. Acknowledge the inaccessibility of cancer care services for residents of Nunavut, and to take action to provide opportunities for positive mental health while receiving care. It is important to note the resiliency of Inuit peoples despite social contexts. And we are committed to implementing the Truth and Reconciliation's call to action and to advocate for accessing Indigenous programs in all hospitals. So for the audience here, I hope that's something that you can take away, what you can do in whatever part of the country you are from. Inquire if your tertiary care center have Indigenous programs. Ask if they do not, ask why not. Advocate for more. So here at the Ottawa Hospital, our Indigenous program is just for the cancer, but we are in frequent talks now to expand the program corporately. So again, thank you so much for the invitation. I'd be happy to answer any questions you may have.
Okay, wow. Trying to stay focused while at the same time just taking notes from all of the incredible information, insights, lived experiences shared by everybody. So just before we begin our question and answer, deepest thanks. Becky, Carolyn, feel free to unmute yourself and go on screen. We have a few questions that have come in on the chat so far. I am encouraging everybody, if you have a question or a comment, please add it into the chat, or if you prefer in the Q&A section, I will look for them. And to get us started, there's a question here for Becky, and then Carolyn, you may also want to comment on it after Becky. Just some of your closing comments there about you may wish. So thank you so much, Becky, for sharing your personal experience along with your professional ones. You talked about the Indigenous focused psychosocial supports that you were able to access as a safety net, and that you wish there were more, including traditional foods, accessibility, home foods, so to speak, that Malaya spoke a little bit more about. This person asking the question is so glad that you had these resources available to you as a caregiver. Were psychosocial and cultural supports also offered to your mother as a patient?
So I just want to identify that there's a limitation at the Ottawa Hospital in terms of providing specifically cultural support that say totally and completely relevant to my mom. By that I mean it's not like the hospital's going to be providing her seal meat or raw ptarmigan or char or like a broth. Like that was my role. I brought that to her. So, and we arrived prepared, knowing what we were getting into. I'm not saying it's not ever going to happen, but I would like to address it. It was very much like mental health support, the physical presence of being with someone, even if it seems like we're bringing a blanket and cards. This is the kind of thing my family would have provided. So if that cultural or not, my mom, I do think that she received a level of support, and I'm not sure that it's necessarily cultural or not, because I was providing a lot of her cultural supports. What we needed most was cultural, but was also very mental health type support, and that's also what we received through that program. And it brought us a sense of not feeling like we're coping so much alone, because we're so far from our own support system as well, from our food systems, from our language, even just being where it's the adjustment to the environment and temperature, and so much like overload of English when we speak primarily in our language. I'm not saying that that's not going to happen, but a lot of the personal support that I've provided for my mom is what was culturally appropriate to her, because that's the way that I'm used to taking care of her. It's weird to kind of label it cultural. In terms of a space, though, the reciprocity for that space, that allows us to also have that reciprocal space to provide, and that's culturally appropriate to us. So being able to give back into the program with a gift, for me to be able to access other things like that my mom might not use. Like I accessed a smudge kit from there. From that program, I could take a nap in that room. I can stop in on my way back. So the access and the space to it was also something more for me. But I know that it was there for the days that if my mom was up for that mobility and want to get off the floor and grab a coffee, I know it was there. She was was not necessarily up for it for the inpatient part of it. As an outpatient, though, it's a place that we need to return to sometimes to not to reminisce. We're processing parts of the journey, and that's a place where we can safely process those parts of the journey with the supportive presence of a nurse navigator too. Does that make sense? I'm not sure if I
Absolutely does. And it made
question.
me think about all of the people who have to travel and who don't have an escort or a caregiver with them. And as you were clarifying more about the types of supports that you were able to provide specific to your mom and anticipate things like, let's bring some of our foods with us, etc. And just, I don't know if you have any comment, but, in preparing for this and with chatting with all of you, I certainly got the impression that there are many people who have to travel to Ottawa and other urban centers for cancer care and other care who may not have someone like yourself, a trained nurse and a daughter fluent in the language to be able to provide all of those additional supports that you were able to do. I don't know if you have any comment on that, Becky, as well.
Well, also that, if we were staying at Larga Bath, they do provide country foods there. So that's a very, very big plus. Like, even if this is a distance for us to travel, it's difficult to access. They're outsourcing from our territory to Ontario. There's specific seasonal foods, and the harvesting activity is very seasonal. So the boarding home does provide that, and many families bring their food with them as well. So they're sending food from up here. Someone agrees to carry it sometimes on the plane and bring it to boarding home because they're going to be there. I'm there for an MRI, so do anyone want to bring their food and give me your food so I can give it to who you're wanting to send it to? So when you think of community level support, there are micro systems that kind of exist in there that you wouldn't commonly know. And this is kind of how our culture operates. We want to give to people who need it. And when it comes to food, we're supposed to share it. So also the nutritional parts of it. So if you're a specific oncology patient, there's going to be times for sure, maybe you not want to eat and stuff. You want some cold, frozen, raw food, the way that when we're feeling unwell at home, sometimes that's what we want, or the hot broth that has these nutritional properties. We want to provide that even to people that are there. Like, I'm traveling on the weekend with my mom. We're already preparing our food, what we're going to bring, just in case we're there for a longer time. We don't know what these treatment plans might look like, but we're already preparing our food and what we're going to bring. And I know that I can call my family, I can call my home community, and they could send us food. If we're there for 2 months, I know that if I call, not everyone has that level of support, but most people can access if they ask. But I'm really grateful that the boarding home has this for people. From my home community, there's specific foods.
That's great. I'm thinking about all of those existing relationships and micro networks that you're describing, and what are the opportunities to be able to actually, optimize those further and just help make those connections for people, and particularly people who may be having to undertake all of this on their own. I don't know, Carolyn, if you wanted to make any comments in terms of the psychosocial supports or other types of cultural supports from the Ottawa Hospital side, feel free to jump in if so. Otherwise, we've got more questions and I can keep going here.
Questions.
Yep.
Yeah, that's fine.
So there's a question here I would love to hear from both of you on, whoever wants to go first. But so, regarding offering more services, we'll stay with cancer care and oncology services now in Nunavut itself, and that capacity to be able to do more there. It sounds like it is a work in progress. It sounds like there are steps being taken. Would either of you like to elaborate more on sort of the work being done to grow capacity to be able to deliver care increasingly in the territory? What seems to be progressing well? What else needs to happen as a priority to be able to support greater capacity to do more closer to home?
if okay, Becky, I'll start. I just like to start by saying that, the Ottawa Hospital, we go up in a relationship. Kikatani General Hospital, we are a provider, but it is Kikatani to take the lead, and we're working together. So it's not TOH implementing what we think should be done when we go to Baffin Island. It's very much learning, listening, and there's been years of relationship building before this happened, right? So if anything,
Important
I would
points.
yeah, you have to form the relationships first, and it's very much a collaboration with Kikatani, taking the lead because it is their land, their territory. Yeah, and we assist as best we can.
Absolutely. So in that,
Okay,
do either of you want to chat? Yeah, Becky, go for it.
Sorry, I can supplement the answer about, and I totally agree with Carolyn that it's like this collaborative partnership. I don't work necessarily directly in that. But what I can tell you is that I've seen firsthand what some of the benefits have been. So when we talk about some of these longer term collaborations and some of the maybe short term results, what I see firsthand for patients to be able to have their infusion here firsthand was incredibly impactful. This is not something, because it's such a private experience, you're not going to see this kind of stuff make the news. When we're offering a visiting oncology service, so say I'm coming from Grise Fiord to Iqaluit instead of Grise Fiord to Ottawa to see my oncologist, and it's closer to Christmas, I know I'm not going to be stuck in Ottawa, and I can have a translator that's speaking in my dialect, or I know I'm going to be at a boarding home that's amongst other Inuit. So if the providing care closer to home part, seeing it firsthand, the oncology visiting clinics, the increase in services. What I'm seeing on the systemic side is more of a lack of preventative patient care, preventative tools. But that's kind of my some of my opinions about healthcare. I have a lot to say about healthcare, but that for me is a bigger piece that I think I think that's going to also be part of the collaboration, is what other things can we do when it's not all about acute care services. You want to see this wellness as a spectrum also. So I'm really hoping that that's something that's considered. But again, that's me being an Inuk and being a nurse. So
I think it's a powerful theme that recurs. That prevention and early detection is so important. Thank you. That's really excellent reflections. A question for Carolyn. Thank you so much for your presentation, and to Dr. Asmus. You mentioned that you advocate for what your patients need, not what health providers think they need. What are some ways that you glean these needs from your patients? What are some of the opportunities and barriers that you face in advocating for their needs?
Well, to start, healthcare in general in Canada comes from a very militant place. Male, militant, Catholic Church. That's the background of hospital policies in Canada. So some of the barriers initially is an ownership of the patient, and patients not feeling like they have a voice, that they have to listen to whatever the doctor says. So it's building that trusting relationship with the patient. So then, I can find out what they say their needs are. And sometimes it could be as simple as certain foods, or it could be, something larger as wanting to go home, not stay in Ottawa for care anymore. It's the full range of the spectrum. And so a lot of my role is advocating with staff that this is what the patient says they want. And it is my job to work with partners in Kikatani, OSNI, the palliative care team, if need be, both in Nunavut and in Ottawa to make the family's requests. And unfortunately, it doesn't always happen. Sometimes folks get too ill before we can get them home. And that just speaks to the distance and the importance of trying to provide care close to home. So for my role, number one, establish trust, build that relationship, and then advocate on whatever they say their needs are. And a lot of the times it has nothing to do with their cancer. It's all the emotional aspects of being away from home.
That's
Clear as mud.
powerful. Yeah. No, not clear. It is clear. No mud. So a question that came up in the Q&A, to follow up on a previous question, would it be appropriate for hospitals to use cultural support programs to facilitate travel for family members to accompany the patient to treatment, not to replace other supports provided through these programs, but to complement them? So, we were hearing a lot about the support that Becky provided with her mother. How can this be the norm so that more people are able to have family and loved ones accompany them and be able to provide that enhanced support that families and loved ones can do above and beyond the excellent programming that you guys are doing as well?
So was the question, hang on now. Was the question, would a traveling cultural support program facilitate providing culturally sensitive care? I feel like it's a
good question. I think it was.
Maybe I misunderstood it.
I think you can answer it both ways. I think it may have been meant as facilitating travel for family members to provide more cultural support, but I also like the way that it could go. Yeah, and would there be benefit to being able to have more mobile cultural support programs able to go to where people are? So the way you interpret it, I think, is also an interesting question.
Okay, so we do have like a medical escort, like a medical travel policy that our government and our health system institutes, and it does allow for one escort, like one support person to travel with you that can be a family or a friend. And this is a 4-week commitment. So if you're there for 2 months and you're a person who is working and you have a family and you're committing to taking care of this person now for that amount of time or longer. So those, it's not so much a cultural program, that's a travel program. Okay, and that's to support patients. The cultural support piece, I'm not sure how that would look. I feel like this would be more like, if I could visualize a program, and if you're providing cultural support, we need to have this off-site, but also have an on-site option. If I could see a place like that, and hiring people that may be also trained on how to provide certain supports, but also bring in their cultural strengths, so that it's not all about this training, but because people have different cultural strengths, they're natural caregivers, they're natural active listeners, and they have an understanding of what our Inuit worldview is, but also our historical experiences as well. So there's also a sense of belonging that I feel like those things are possible, but the way that I visualize it is not where it actually exists. Even in my own institution, this is not even something that's accessible here in our hospital, but we managed to access it because it's part of our microsystems culturally. So if people are looking for a spiritual support and I'm their nurse, I know who to call. If they're looking for certain foods, it's not the cafeteria that's going to provide it. I already know who to get my stuff from, and family members know where to get stuff. But it's not like, someone from Igloolik who's new to here, that's going to be more difficult for them. Do I want it to be more accessible? Do I want to formalize a program? I would want to see that to be developed, like as a development. The microsystems already exist, and a place like Larga is going to support that through our food. It already supports it through a common place to speak our language and to have a gathering space. But what we need is a place that's a safe gathering space. Some of the places we need to process difficult times, some places to go through anticipatory grief, some places to process the extremely stressful times and lonely times. So would I want to formalize something? I would love to. I don't know that it would be called a traveling kind of, cultural program or that kind of stuff, but it would need to be multifaceted. And again, an on-site version and an off-site version is what I would visualize. Just to be,
it's powerful.
Really cool.
I'm imagining those, as you call them, microsystems. It's like, it's really, and it's the strengths, it's acknowledging and becoming like very formally and specifically acknowledging all of the strengths already and all of the relationships and all of the good things happening in community already. And how are you creating that as part of a more formalized approach to being able to create those supports? And so it's not just about, it can become more part of how the formal system is operating, and not,
yeah.
We tend to think through the deficits, right? We see it's certainly in our culture, in mainstream culture, we tend to see through the deficits, and we miss all of the strengths and beauty that is there, and we aren't actively acknowledging and incorporating in partnership. How do we then make those strengths and that beauty, how do we make that accessible widely, so that people who are using the system can benefit from them?
Just to kind of add to that, like I was thinking about this because I think culturally I would have had a matriarch to go to when I was struggling as a caregiver. So if I had access to a matriarch type person who's caring, that is there as part of the system to support me, that to me would have been like, again, an additional tool to the entire process. But that's an example of how meaningful it would have been to have a cultural support system within the existing systems. So I don't know if this makes sense.
No,
I
absolutely,
like
it does
so much in
completely.
English. I'm thinking it in Inuktitut. I'm trying to tell you in English.
Your translation is excellent. And there's I'm wondering about for Carolyn, do you have any recommendations? You did a call out around our need as patient groups and audience members to be advocating, going to all of our different hospital sites, and there's other types of settings where there are Indigenous specific programs or teams that do exist, but it's not systematic, it's piecemeal. Maybe it exists in your area, maybe it doesn't, maybe it serves a given community, maybe it doesn't. So any further commentary on how opportunities to further grow your own team's capacity within the Ottawa Hospital? And I know it's in partnership, but it's right now, I think it was Mackenzie who mentioned it. You're a couple of people and you're specific to cancer care. So is there anything that you would say can be done to help grow that capacity where it already exists? And then I know that there are Indigenous nurse navigators here and there in different parts of the country. Any advice, opportunities, recommendations on how we can, as patient groups and as healthcare stakeholders, help advocate for there to be more Indigenous nurse navigators in more places across the country to be able to do some of this important work?
Truth and reconciliation calls to action. Healthcare calls to action, I believe, 18 to 25. And, it's leadership down, right? We've been advocating for years, and we can only do so much. It is to bring, that awareness and that to the higher tables of, like, the calls to action are there. What is taking so long to implement? Our program here, we have a blueprint, we have a framework. We're tired of consulting, right? We shared and shared and shared. So there's power in numbers, there's power in partners. So that's one way for sure. And in terms of learning across the country, we get a lot of requests. What's good resources, cultural training, sensitivity, providing safe care. I would, there's a national lens of Indigenous history, but I would encourage folks to look at the local regional lens of the Indigenous people of where you are, and to learn more about, the specific characteristics. One of my biggest pet peeves here is the pan-Indigenous and folks not knowing the difference between First Nation, Inuit, and Métis. Even though we've been providing care, the tertiary care center for the Inuit, for over 20 years now, right?
Yeah. So or the 650 different nations of First Nations, to the earlier points. Yeah.
So
yeah.
We get this, people want a simple answer, right? People want, like, what can we do? Like, what is it I can do? You start by learning your local, who are in your local areas. Are there local powwows? If you want to learn about Nunavut, go on social media, CBC Nunavut. There's an ocean of resources out there. You don't need to take the official, like a movie, for example, The Grizzlies. If you want, to learn more, The Grizzlies movie, a fantastic Canadian movie, Inuit-led. So many resources. You just have to kind of pick what do you want to learn, right?
Yes, thank you. Absolutely. Yes, yeah. I think a number of our presenters today shared, numerous reports. There is no shortage of information, let alone right inside of your own communities. Who is here? Who do I need to get to know? What are those relationships that I should begin to build? I just want to acknowledge the time. We should move into breakouts at this point, but I want to reflect on when I was listening to you, Becky, and you were talking about more of the cultural strengths that would have been so powerful for you to be able to access, such as the wisdom of a matriarch. To continue to grow the spaces that for people to be safe within and to process the emotions that they're experiencing, caregivers and patients and loved ones. And that just brings me back to something that we heard over and over again yesterday, and that our keynote speaker tomorrow will be starting off our day with, which is, it's become a bit of a technical term, and it's going to be another buzzword, but co-design and, real partnership from people who are using or trying to the earlier point of Tim, the people who are never actually touching the system in the first place. We need to be very meaningfully learning and incorporating what's learned into what's happening within our various care provision and policies and at the various levels of the system through that very meaningful co-design. Just the wealth of wisdom and information coming from Becky in just sharing about the types of supports that she anticipated and brought, they were able to access when they were there, and then that would have been even more helpful had they been in place. There's a wealth of information within there about how healthcare systems can become more adaptive and actually meet people more and more where they're at with what they need. And even when when the language, the culture, et cetera, is very different from our own, we need to be in meaningful relationship. We need to be working at that point of how do we design something? How do we improve something with people like Becky and her mother, and all of those men who are not touching care in the first place, whatever that looks like. They need to be very meaningfully informing everybody within healthcare about how to do better. Would you guys like to share any last thoughts before we go into breakout?
Sure, I can maybe, I didn't include my last slide, but it's more food for thought and a lot of what we already talked about. Some of the other things I didn't talk about that would maybe it belongs in a different conference. or something was about culturally sensitive palliative care and being able to palliate at home and how challenging that is in Nunavut. So food for thought, put it in the back of your mind, but maybe think, well, how would that look like in Baffin Island? I can't think of anything else. My mind is super full of, like, I feel like my mind's in Ottawa a little bit, and I know I'm going to be there really soon and be able to revisit those spaces again and stuff. So I really appreciate everybody's time. I know that my presentation is very it's different. It's like the nursing and patient kind of caregiver stuff, but maybe more the caregiver side from an Inuit lens from a distance. So thank you all for listening to my story and my mother's story. Thank you for your support.
Thank you for sharing it. It's deeply appreciated. And thank you, Carolyn, and please extend our thanks to Dr. Asmus as well. We will now be moving into breakouts. You will have a facilitator, and we really look forward to hearing what you guys are sharing. We will take what you're sharing and we will theme them, and we will make sure that we're chatting about it when the patients and caregivers and patient groups get together on Friday. So enjoy your breakout sessions, everyone. Have a great evening once they're over, and we'll see you hopefully tomorrow for our last day of content.